My sound was not conveyed. So I just going to go through again for those that didn't join this morning session. So this is just a very brief overview for our consultation for station 2 and 5. You can see that uh, ideally we should take about 8 to 9 minutes for history, 3 to 4 minutes for examination, and concern. I would advise for 3 minutes, full 3 minutes, because you have 5 or 6 concern instead of just 2 or 3. And then Viva is 5 minutes. Okay. And another thing is that the regarding the history is, I just want to repeat again, because history actually we tend to be very jumpy, especially in the old format BCC. Nowadays, I feel like for new format, we should really go a bit structured. And by right, when we ask for presenting complaint, history presenting complaint, you ask for systemic review as well as excluding your differential, and then past medical history, drug history. If it's female, I will ask about a bit of female history if it's relevant. Then, if the time is short, I will straight away go for examination. But let's say the time is adequate and then I feel it's quite comfortable, I will straight away continue my history taking until social history. Only then I will examine the patient. So there's no right or wrong. I would say that the only way is to play safe in a way that you must make sure that you allocate enough time for each component, especially the concern. Concern, we really need to spend a good amount of time for concern. And then examination cannot be touch and go. We must really examine the patient and get the, if try to think as you are the examiner, and if let's say this is the STEM, what are the things that you expect a candidate to find, and what are the things that you will write on your calibration sheet. This is how we should think as a candidate point of view. Okay, so this is the proposed allocation, but no hard and fast rule. This is just my way of interpreting the exam, and the last 4 sentences actually extracted from the RCP. Not necessarily we have to complete the history, like I say, before examining patient, and we are expected to explain the probable diagnosis and plan the management together with the patient. If let's say part of answering the concern, okay, and we should also discuss options with your patient and agree and negotiate an agreement. Let's say there is any issue, and also answer all the concern. And this is the important part, addressing the patient view on the issues, including the non-medical one, in which we are not expected to just concern on the medical diagnosis, medical point of view. We also need to explore a bit on the social background, any issues, working environment, any issues, financial, family, and the dynamics. So all these are also quite important, and clarify what is the what matter most to them. So that will be it. Okay. So let's practice. We'll start with Dr. Karen. Yeah. Are you ready?
Yes.
Okay, I will give you 5 minutes for preparation. Your time start now. Okay, time's up. So this is the patient, Madam Catherine. You may start now.
Hi, Madam Catherine. I'm Dr. Karen. May I confirm your name and your age, please?
Yeah, I'm Catherine here. I'm 35 of age.
Okay, hi, Madam Catherine. We are here to discuss about your medical problem, and at the same point time, I'm taking some notes. Are you okay with this?
Yeah, sure.
Okay, Madam Catherine, I've come to know that you're having this difficulty swallowing for the past 3 months. Can you tell me more about it?
Yeah, so doctor, I've been having very difficult to swallow, and this thing has been occurring for about 3 months. So initially, I don't really have much issue, and subsequently, I realized that the food tends to stuck at the level of my chest when after I swallow the food. Sometimes it happens, sometimes it does not. But recently, I realized that this thing has been progressive and persistent. So I'm a bit worried. I feel like I want to choke if let's say I cannot swallow meals.
Okay, Madam Catherine, I will try to help you. So may I ask further, do you have difficulty swallowing solid food or liquid or mixed?
I mean, I can swallow, but I feel like the food doesn't go to my stomach. It feels like stuck somewhere in between.
So both at solid and liquid, you'll find it difficulty to swallow. Is it correct?
Yeah.
Okay. Does the symptom usually work in the evening or is throughout the day?
It is throughout the day and night.
All right. So do you have any speech problem? A problem with your talking and all that?
Yeah, I think quite okay. I don't have any hoarse voice. It seems normal for me.
Okay. Do you have any color change over your hand?
Color change as in?
When your hand fingers are exposed to cold, does your color change over your hand?
No.
Any joint pain?
Joint pain, yes. In the past, I used to have this joint pain over my fingers, but it comes and go, and I don't find it disturbing. And now I don't even have any joint pain.
Okay. May I know how long does the when does it started the joint pain?
The joint pain has been there for almost 1 year already, and then sometimes when it comes, usually associate a bit of stiffness. I feel when I wake up in the morning, a bit of stiff when I want to use my hand. But subsequently, after a while, perhaps about 15 to 20 minutes, I feel okay. And then it comes and go. And then sometimes it happen for a few weeks, and then it actually resolve by itself.
Okay. Do you ever seek any treatment for the past 1 year?
I used to take a bit of Panadol, let's say I have pain for the joint, but generally I didn't go for any doctor.
All right. Do you have any tightening of your skin?
No.
Okay. Do you find any do you have any weight change recently?
I think my weight is quite static. I've been trying to keeping fit. So I try not to eat too much, but I think my weight has almost static.
How's your appetite?
My appetite is actually good.
All right. Do you have any when you are exposed to sun, do you have any rashes over your face?
Yeah. Now you say that, I realize that over my face, especially my cheeks area, sometimes I will notice a bit of rash lah. But I tend to use a lot of makeup, so doesn't look obvious to me.
Do you have any mouth sores?
Yeah. Sometimes also for the past 6 months, I realized that I easily have some sore over my mouth, and this is quite painful when I eat. But now the mouth sore have already resolved as well.
All right. So do you have any chest pain?
Yeah, sometimes I mean I do have a bit of chest pain, especially when more and more food are stuck at my chest level. I feel a bit of discomfort.
Okay. All right. I will try to help you.
Mm.
Do you have any difficulty in breathing, feeling breathlessness?
No.
All right. Okay. I'll just run through a few questions. How's your urination? Any blood in your urine?
No blood, but I realize that my urine is a bit frothy sometimes, especially in the morning.
Do you do you notice any blood in your urine?
No.
Do you have any pain when you're passing urine?
No.
Okay. How long have you noticed your urine being frothy?
Not very sure. I thought that's normal for me actually.
Okay. All right. Okay. All right. So besides that, do you have any numbness over the hand or any weakness anywhere?
No numbness or weakness.
Okay. Do you have any cough?
No,
Do you do you have any tummy pain?
no.
Any vomiting?
I don't have tummy pain or vomiting, but sometimes I feel a bit of discomfort over the upper part of my tummy. I also have a bit of heartburn as well. And because it tends to bloat out if I swallow, I mean the food stuck, right? After that it will go down slowly, and then I will start to feel all these kind of gases sensation.
Do you have any like or you will feel the acid coming out from feeling sour
Yeah,
sensation
yeah,
over your
yeah.
tongue?
Yeah, there is.
Okay. Do you have still able to pass motion? Is it,
No.
I mean you still able to pass
Yeah, yeah, I still able to
your
pass
bowel?
motion.
Okay. All right.
Mm.
Do you have any fever?
Any what?
Do you have any fever?
Oh, fever. No, no.
Okay. Do you have lumps and bumps or anywhere?
Not that I know of.
Okay. Madam Catherine, do you have any medical illness previously?
Yeah, doctor, I was told to have anemia. The doctor told me I have a low in red cell, and that was detected during my first pregnancy.
Okay. Any further workout done during for this anemia?
Yeah, the time when the doctor took the blood, they told me that my iron level in the body is a bit low, so I was started on the medication called ferrous fumarate.
Okay. Did the doctor repeat your blood after that?
Not really. After that, I didn't really follow up. It was the uh OG doctor. So after that, I just took the medication by myself. I didn't check.
Do you frequently taking any painkiller over the counter for your joint pain?
Panadol, yes, but I try not to. Other than that, I don't have any medication.
Okay, all right. Did the doctor say your other blood counts are low? Any bruising anywhere else?
Mm, like I said, the last blood test was like almost 1 year ago when I was pregnant. Then subsequently, I didn't go for any follow up. During that time, the doctor told me that only my red cell is low.
Okay. Any previous surgical history, surgery done?
No.
Okay. Madam Catherine, are you married?
Oh yeah, wait. You mean surgery, right?
Yeah, surgery.
Yeah, so 1 year ago, I mean during my last pregnancy, I have an emergency cesarean section that time because my baby that time actually have low, they say it's actually having a low heart rate. It's not safe. So have to deliver early. And then my baby was actually monitored in the ward and subsequently able to discharge well.
Okay. Did the doctor say your baby is the heartbeat is extremely low or any abnormal heartbeat?
The
Did
doctor
the doctor
says
ever say that?
the doctor told me that my baby heart rate was quite low, but did not tell me whether it's irregular or not. But it just say very low, and then after the baby is out, and then subsequently it's okay.
All right. Okay. Do you have any family history running? I mean significant history among your family member?
Family history of like
Uh, any uh any any cancer?
no,
Okay. May I know, do you have ever had any miscarriage before?
no.
Okay. Are you taking any hormonal pills?
Yeah. I'm taking this hormonal pills, because I'm on family planning now.
Okay. Do you ever have blood clots in your leg swollen, or any blood clots in your lung before?
No.
Okay. All right. May I start to Madam Catherine, can I start to examine you?
Yeah, sure.
Okay. I would like to look at the patient hand. Is there any joint swelling or redness?
Yeah. So when you look at the patient hand looks very normal for you. You don't find any. You feel for the hand. And look at the hand, there's no obvious synovitis, there's no obvious redness over the joint, no obvious tenderness.
Any tightening of the skin? Any obvious telangiectasia over the face?
No.
Okay. I will look at the face. Is the patient anemic now?
Patient is pale,
Okay. Is the patient jaundice?
patient is not jaundice.
Does the patient has any malar rash, microstomia, anything like this?
Yeah, unfortunately, patient is having makeup. She also told you just now, she say cannot really appreciate.
Okay, I'll look at the patient mouth. Is there any oral ulcer?
Yeah, there is two oral ulcer, one at the right upper pole of the mouth, and another one is at the left lower pole.
Any obvious alopecia patch over the hair?
You, uh, she's actually wearing wigs, so she did have alopecia if you ask her.
Okay. Pinch the skin. Is there then tightening of the skin below the elbow or above the elbow?
No.
Right. I'll auscultate the heart. Is there any loud P2?
No loud P2?
I'll quickly auscultate the lung. Is there any crepitation heard?
No crepitation?
Okay. Madam Catherine, may I know what do you work as?
Yeah, doctor, I'm actually a full-time model, you see. So I always make up myself, and then yeah, so I used to work a lot, involved in a lot of these events, but because of this difficulty to swallow and also a bit of pain here and there, I have been very distressed, and I don't know how my life is going to be.
I'm sorry that you are going through such difficult condition. I'll try to get to the bottom of this and try to help you from here.
Hmm.
So, may I know, are you a smoker?
No, I'm not, but my husband is a smoker.
Okay. So, are you taking any alcohol?
No, no, no.
All right. I'm sorry to ask a bit of sensitive question. Okay. Do you have any high risk behavior? For example, any casual sex?
No, no.
Okay. Just now you mentioned you delivered once before. May I know how many children you have?
Only one.
Okay. All right. So, I Madam Catherine, may I know do you have any question for me?
Yeah, doctor, do I have throat cancer?
Madam Catherine, from what you have information that I have gathered and explaining you, I think you are likely to have a throat cancer, given that you are like a young age. And actually, I'm thinking you are having an autoimmune system where there's your immune system misdirected and it attacks your own body. It attacks your multiple organs, including your skin, your kidneys, um, and but I have to run further tests to confirm it.
Oh no. What is this, doctor? Is there any specific name for this condition?
This is actually I think it's a mixed connective tissue disease where you might have two autoimmune condition at the same time, and but I need to run further tests to confirm this.
Oh, okay. So is it curable?
I'm sorry to tell you that this condition is not curable, but then it's controllable. We can control its symptoms and prevent it from getting attacking your organs by some medication, and it can improve your symptoms
Oh, will
and
will
slow
my
down the
child have
progression.
the same problem later on after he grow up?
This condition is actually not inherited, but then compared to the general population, your child will have a slightly higher risk compared to them.
Oh, okay. Then can I have a camera test? Because I'm very worried because I worry the food, maybe part of the food is always stuck there that that's why I have a difficulty to swallow.
Okay, for the camera test so far, I think we can first proceed with the non-invasive test first, which is less causing less lower complication rate. We can proceed with some blood test first, and if it's needed, then only we will proceed with the camera test. But so far, I think we don't have to do the camera test for now.
Oh, then do I need surgery for my throat problem?
Madam Catherine, so far I think you don't need to have surgery done first. I think we can start you on some medication to control your symptoms. But sorry, Madam Catherine, can I have a look at your mouth?
Sorry,
Uh,
sorry. 1 minute
yeah, I
left. I
want.
forgot the second minute.
Okay.
Okay, 1 minute left.
I,
You want to look at the
I
mouth,
look.
right?
Yeah. I want to see any upper obstruction, for example, enlarged tonsil or any abnormal growth inside the mouth.
No,
I'll see any candidiasis over the tongue.
no,
Okay. All right. Madam Catherine, do you have any other question for me?
no.
Okay.
No more question, doctor.
Oh, okay, Madam Catherine, I would like to I suggest you to stop your hormonal pills for now also, because if you are confirmed to have this autoimmune problem, hormonal pills might cause you to have higher risk of getting these blood clots in your body, which can be
Oh,
life-threatening.
I see,
Yeah,
doctor. Hmm.
I will refer you to the woman doctor, and we can try to change the other kind of contraception method, which is more suitable for you. Is this okay for you?
Yeah, okay.
All right. Madam Catherine, so I would like to summarize your case. You have been this difficulty solving for the past 3 months, and it's both solid and liquid food, and it happens throughout the day, and you are also
Okay,
having
time's up.
some.
Okay, thank you. Thank you, Dr. Karen. Time's up. Okay. Now it's a session. Can you talk to me regarding the differential diagnosis and working diagnosis for Madam Catherine?
For mental catering, my topmost diagnosis could be it's a mixed connective tissue disease where the SLE overlap with the systemic sclerosis. And
Mm-hmm.
also, I would like to rule out the local causes as well. Is there any obstruction over the esophagus, for example, esophageal CA, or any esophageal esophageal dysmotility problem, or any gastritis problem, or any hiatus hernia causing the reflux.
Mm-hmm.
And yeah,
Yeah,
I think
probably reverse back a bit on the mixed connective tissue disease. I know you have
mm,
able to elicit some SLE-like symptom from the history. How about
mm,
the systemic sclerosis? What are the points towards systemic sclerosis?
type patient has system skills. The patient has esophageal dysmotility syndrome
Mm-hmm.
symptoms, but then the patient don't have any Raynaud phenomena, don't have any telangiectasia, but patient have having also some joint pain.
Mm. So another clue to suggest mixed connective tissue disease is the patient having any weakness of the muscle?
She said no.
Hmm. So probably unlikely, less likely, right? So
Mm.
how do you explain this difficulty to swallow in a patient with the have SLE symptom?
Um, as a um, difficulty to swallow. Um, I'm not sure about this.
Oh, okay, no problem. And okay, is there any other differential diagnosis you want to include for this patient?
Mm, mm, I mean the local causes and the cancer, esophageal cancer, and then also the gastritis and also the hiatus hernia. I don't have other. The neural causes are unlikely
Mm-hmm.
because the patient has no speech problem and only the weakness is throughout the day. I'm thinking myasthenia gravis, but then it's unlikely because the weakness, the symptom is throughout the day and there's no speech and no weakness, no speech involvement and no weakness. And yeah, couldn't think of any others.
Mm. And patient also have anemia, right?
Yeah, but I'm thinking anemia is like part of the SLE. And then
Mm.
mm, mm,
Okay, never mind. How will you work out for this patient?
I will do a MBC to confirm the patient has an anemia and make sure the patient don't have any lymphopenia or any thrombocytopenia, which could be part of SLE as well. And also send for ESR, CRP, and also send for autoimmune workout, ANA, double strand DNA, and then for if you want to rule out systemic sclerosis, I will send for anti-centromer, anti-topoisomerase, anti-RNA polymerase. And the patient mentioned that the child so-called has a heart block symptom. I would like to send for anti-RO, anti-LA. And I would like to do a esophageal motility test for this patient.
Mm.
And I'll do a chest X-ray, ECG, and yeah.
XXV ECG. Okay. You mentioned about anti-low, anti-ra. What does this point to?
If anti-RO is positive, then the chance could be higher. So the child has risk of heart block, congenital heart block.
How about the patient?
Yeah, I think the patient has because the patient say the child was delivered early and was told that the heartbeat is a bit low.
Mm. Okay, never mind. How will you how will you manage this patient?
Uh, I will um it's a multidisciplinary approach where this patient has difficulty swallowing. So I refer patient to the dietitian first, and also I refer the patient if it's a confirmed SLE case, I will involve rheumatologist, and also
Mm. Involve pneumatology for?
to manage on the underlying disease SLE.
Mm-hmm. What can they do?
They were stuck on steroid and also immunosuppressants, for example, hydroxychloroquine, azathioprine, or any
How
MMF.
about the difficulty to swallow? How to kind of like treat that?
Difficulty to swallow, we can start on the try to give some Nexalon,
Mm-hmm.
mm,
Okay,
and
time's up. Okay. Yeah. But please continue. How will you treat the dysmotility, so-called esophageal dysmotility?
um, give we can try Nexalon, ES, and
Mm.
yeah, the
She
others
also
I'm
have
not
a bit
sure.
of GERD right symptom, right? You can start patient on PPI as well.
Mm,
Mm.
mm,
Can consider domperidone, those kind of things. But you haven't got the exact diagnosis for this patient. I thought you almost got it. I thought you already got it, but what is the you say that if
mm,
anti-RO or anti-RA is positive, that means the
mm,
baby most likely will have some neonatal lupus, right? With a congenital heart block, right? How
yeah,
about the patient itself? What does this mean for the patient with SLE? What diagnosis does the patient has?
mm, I'm not sure.
Not sure. It's a Trojan.
Mm. Oh, okay, yeah.
So the diagnosis is actually secondary Sjögren's syndrome. Perhaps it's to say Sjögren's syndrome secondary to SLE.
Oh, but I didn't manage to ask the dry eye and all that. Yeah.
Yeah, that's why you didn't talk of children because in the history you
Mm,
didn't ask about that, and therefore I decided not to help you. I say, if you ask me, I will say my eyes is actually red and then very dry easily. My mouth also very dry. I need to drink a bit more water, but because you didn't
mm,
mention that, so I decided not to say because it's actually quite a crucial information to ask for any patient with autoimmune disease. Huh? So, but yes, this can be mixed connective tissue disease. But if you're suspecting MCTD, other than checking systemic sclerosis feature and SLE, you also need to screen for polymyositis, right?
yeah.
How do you check for
Mm.
polymyositis?
Ask for any muscle pain, muscle weakness.
I mean for examination.
I have to check the proximal myopathy
Yeah, so this is
and
something expected. We really need to check the proximal ability. You can see that you spend for examination, you only spend perhaps 1 to 2 minutes. It's quite short, right? You examine the lung, examine the heart, and then abdomen, I think not much of sign, right? When you ask for it.
um,
And then you examine the peripherals and the face. Yeah. So, yeah. But basically, this patient is actually having esophageal dysphagia, right? And on top of that, she
mm,
also have IDA and SLE-like symptom. So, yes, I think your diagnosis is correct. Just that you didn't manage to offer me the cause of the dysphagia, which is quite important. You should mention that this is maybe it's a Sjögren's syndrome. It can be
mm,
esophageal dysmotility syndrome. And
mm,
young patients stress, it can also be functional, but function is down the list because there is something organic to explain. But let's say this is a functional, what would be the diagnosis? Let's say no SLE, what would be your differential diagnosis?
mm. Functional, mm, conversion disorder.
No, 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 no. Conversion disorder is something that patient cannot control but having the symptom, right? But let's say
Oh,
this is something like it's a functional GI disorder, then what would this be classified?
not sure.
So it's also part of the syndrome, it's a functional dyspepsia, lah, no? Part of the syndrome. Functional dyspepsia also can have difficulty to swallow, no? And yes, but there's one diagnosis that I feel we should include, especially in the young lady, although sometimes may not have a weight loss, usually will have a weight loss, it's achalasia. Achalasia is
Mm,
something that we need to include, especially young lady, young lady, very slim, very thin, although they say they have no obvious weight loss, because they are thin to begin with, lah. I mean, they don't lose any weight. They are very thin and appetite may be quite okay, doesn't have any change. That's why achalasia is something that you really need to consider, lah. No? I have encountered quite a few achalasia back in HKL, and most of them are like the same spectrum. I look at the patient walk in from the gastro clinic, refer to you even as a new case, and so this one macam achalasia. So achalasia is something you should include in analysis. And for this patient, because of the IDA component, if you
mm,
if you if you omit the SLE part, yes, the IDA can be due to the SLE, but it can, let's say
mm,
it's not really due to SLE, you must also give a differential diagnosis for IDA and esophageal dysphagia as Palmer-Vincent syndrome. This is something that you should include as well, but not, I mean, not in this case, but it's worth to put under your differential diagnosis. Okay.
Okay.
Yeah. So just to go back, I think your history for the presenting complaint is a bit short because you ask quite brief. I mean, I offer you quite a lot of details as well. I say the food side, the throat, and then no issue in initiating the swallowing, and then subsequently also got some heartburn sign of symptom. But you should also ask whether there's any food coming out. You ask about choking or not.
No, didn't ask.
Yeah, and you did ask about any change of voice, any abnormal speech lah. But I feel abnormal speech is like a very scientific name. You should ask any change
Oh,
of voice. Yeah, I mean, this is a very layman term lah. I mean, it's not considered a jargon lah to me, but it just feel weird when you say any abnormal speech. It's like very template kind of thing. But try to make it like very casual. Any change in your voice, any cough, any choking episode, just like that. And then you ask whether the initial symptom, whether difficulty to swallow solid first, followed by liquid, or liquid then solid, or is both. Okay. So for this patient, actually initially solid then liquid. Actually, when you ask her, she said both also difficult because now memang both also difficult. Okay, but you need to explore the initial part because you didn't ask me which one come first. You only ask whether is it difficult to swallow one or both. Okay, you should go back and ask about initially, do you have any difficulty to swallow solid food first and then followed by drinking water, or it's actually the opposite. Okay, and then yes, you ask about weight change, chest pain, and do you ask me about painful swallowing?
no, I didn't.
Yeah, because painful swallowing will suggest esophagitis lah. And commonly it can be due to like what you try to rule out, the candidiasis, or even some form of Barrett esophagitis, or eosinophilic or radiation kind of esophagitis lah. So this is also very important. And for any for any patient that come in with GI symptom, although she's young, we still need to rule out any red flag, no? Because red flag will decide whether the patient need to scope or not. This patient actually you need to scope because got IDA, young IDA should never omit the young IDA, although it can be explained by SLE. But at the same time, patient also got warning sign, which is the dysphagia. No? So this patient definitely needs a scope. And then another thing is that so other warning sign you didn't explore is actually really any early satiety or not. Any easily full after despite eating just a small meal. And then you have to ask whether the other GI signals are important. You have to ask whether any passing of blackish stool, although it may not be important in this case, but it's important because patient already got IDA, right, from the history. So you need to really explore the full GI symptom. Painful swallow, difficulty to swallow, early satiety, weight loss, unexplained weight loss and appetite you ask, and then any vomiting, recurrent persistent episode of vomiting, any passing of blood in the stool or any blackish stool, you should ask all that together, just like a bundle thing for the red flag. If everything negative, then yes, you can tell the patient this is something functional. You may not need to do scope, you can start with medication, but definitely for this patient not. You got so many red flags there, need to work out as well. Okay, so yes, OCP is something that is good. You counsel her, you should probably stop in the background of possible SLE. And then, yeah, actually, I didn't manage to listen whether there's any anemic symptom from the history that you want to ask. You only ask me whether I got any shortness of breath. If you ask me one short sentence, I would definitely say no. So perhaps you want to ask about anemic symptom, you have to ask a bit more. Do you have any breathlessness when you walk a long distance or when you do activities? Do you have any dizziness? Did anyone tell you you look pale? Things like that. I know your examination, you found there's a pallor, but in history also you should really explore and also orthostatic dizziness as well. Change position, do you feel dizzy? Things like that. Okay. So yeah, other than that, you're okay. Most of it is okay. And perhaps another thing is that because she told you she got 40 urine, right? Perhaps in examination before you complete before you complete, you can just tell the examiner I also want to order for the bedside urine dip. Okay. And if you didn't mention that, it's okay. You can also mention that during the discussion. But sometimes you may forget because so many symptoms, so many complaints, and you want to really rule out SLE, right? You didn't mention C3 and C4. I realized you mentioned anti-DS DNA, ANA, and also the MCDD panel. and the other like anterior anterior, but I didn't mention about C3, C4. It's important because I want to make sure the SLE is not in flare, it's in remission. Okay. And yes, the provisional diagnosis for this patient is actually secondary Sjögren with SLE. No? That Sjögren itself causes the dysphagia. Okay. So the concern part, throat cancer, no. Condition curable, most likely no. You say yes. You say correctly. And then child have same problem, difficult to tell. Like I say, I think it's okay. Camera test, definitely the answer is yes. Do I need surgery? Yeah, yeah, I agree with you. Probably at this point of time, no need first. You have to. So what was the management for this condition? If you know the diagnosis is Sjögren with SLE.
Refer eye to manage on the dry eyes.
Mm.
Still involve rheumatologist.
I mean, you cannot just say refer rheumatologist, right? You need to mention about, yeah, you mentioned about immunosuppression and steroid. So perhaps for me, I will not mention steroid. Steroid for some examiner may be I would say a bit prohibited. Steroid is given during a flare, but this patient we are not very sure, right, whether patient is in flare or not. The safer way to answer this patient is to start patient on disease modifying therapy. That's all, EMATs. And definitely immunosuppression backbone consisting of hydroxychloroquine. If you talk about that, you will mention that other than referring ophthalmo eye colleague to look for the eyes, to give some artificial eye drops, also want to screen for retina because thinking that the patient will definitely require hydroxychloroquine, risk of retinal toxicity, right? So sometimes the management is not just mentioning one thing and another. Must also mention a bit why you can see that when you refer multidisciplinary, you want to refer for what reason, and then what are the other things that they can help us to co-manage. The same applies to our real life. So for this patient, you will say I will refer the rheumatologist to manage the SLE and probably need to start on disease modifying therapy. In terms of the Sjögren syndrome, to treat the dysphagia, first I will relieve the reflux symptom. I will start patient on this domperidone, PPI, or even MMT. You want to give some other things and advise on non-pharmacological intervention. For example, ensure that she actually sit up when she eats, and then avoid large meals, especially before sleep. And then, for example, avoid any spicy or any irritative food, things like that. Then for the eye, you say yes, for artificial eye drops. For the mouth, actually, there is also artificial drops as well that can actually lubricant the oral cavity, and that may actually helps in terms of swallowing as well. They don't have difficulty in swallow, but what usually occurs is their throat is very dry out. So if they give some, if they give some lubricant kind of fluids, other than the lip balm, sometimes they actually also help to kind of like make the mucosal lining of the esophagus become a bit wet. But generally, should try to avoid food that can injure the mucosa layer. Try to avoid those hard food. Can say probably at this moment you can have to advise patient refer to dietitian for any soft diet first. Once the symptom gets better, maybe they can try with a normal diet. This is also another thing that you can mention. Other than just focusing on medication per se, sometimes a lot of things is non-medication related. For example, soft diet, for example, eye drop, things like that. Okay. And other than that, I think that's fine. Huh? You got any question? Anyone have any question? No question, Mr. Karen?
No question from me.
Yeah. So do you have my notes, by the way?
Yeah, I have.
Yeah. So if anyone that have my notes can actually look at the 135, page 135. This is actually how we learn about dysphagia. If you learn about this approach, the one that actually on the right upper corner is the important thing. Actually, regardless of what words that I wrote there, to be honest, when I go into exam, I only remember the small box that I created, which is in a case of esophageal dysphagia, in which esophageal dysphagia is very characteristic. They don't have difficulty to initiate the swallowing. Usually the food stuck at the throat level or at the chest. And usually they will not have difficulty they will have difficulty to swallow solid first, then followed by, if you get worse, then you follow by liquid. As opposed to oropharyngeal dysphagia, like a stroke patient, we think back when you assess any stroke patient, we give water already, somehow choke out already, right? Or cough out. So those are they tend to not even able to initiate swallowing for water. But sometimes if you give some like Jerry patient, if you add some puree diet, a bit of solid component, somehow they can swallow one. Oh. So this is the oropharyngeal dysphagia. So in which water is worse than solid. Okay. So this is how I remember usually. And then another thing differentiating point is that esophageal dysphagia tends to have some reflux symptom because it's usually irritate the stomach and the lower esophageal sphincter as well. And then usually they may or may not have some weight change. And then for oropharyngeal, usually because of this aspiration symptom, they will have choking, they will have cough, they will also have a bit change in their voice. So let's say you are encountering with any patient that have esophageal dysphagia. The next thing you need to ask is only a few questions. You need to ask whether patient have any very predominant reflux symptom. Basically, most of the patient will have a bit of reflux symptom, but whether or not this patient only have reflux symptom without any other thing else. So if a reflux symptom only, then definitely you are talking about gastric stricture. And yes, if everything normal other than functional, there is also a possibility of psychiatric related condition. Had to assess the mode, make sure that this is not globus hystericus, which can occur as a part of psychiatric condition. But generally, I don't think it will come in our exam. Just something worth to be mentioned, especially in dealing with functional dyspepsia, one of the differential diagnosis. And the next thing on top of reflux symptom is whether the patient have any painful swallowing, which is odynophagia. If patient have painful swallowing, then you're thinking of esophagitis. So there's a few esophagitis that you need to exclude. First is the Barrett esophagitis. And second, Barrett esophagitis, most of the time is a progression from chronic reflux. So no obvious symptom per se other than reflux symptom plus odynophagia. That's all. Okay, but they don't have any other warning sign. Other than Barrett esophagitis, another one is the high risk behavior. That's why it's also important. On top of that, also need to make sure that traveling history is needed in this patient. Let's say patient recently traveled back from Africa, and then few months later developed dysphagia. You really need to make sure that you're not dealing with Chagas disease, which is quite rare in it's almost none in our population, but can be quite common in Africa. So something is important. Sometimes traveling history and high risk behavior for certain scenario is important. And for this scenario, you are dealing with whether you are dealing with any form of esophagitis, for example, Candida esophagitis, HIV, CMV, or even Chagas. Usually those are the one tends to attack the esophagus. Then the next one is eosinophilic esophagitis, usually related to medication. For example, not really the medication, sorry, that one is different. Eosinophilic esophagitis is most of the time dealing with some form of allergic history. Got some atopy, some medication, some rash, and then usually they sometimes they will have intermittent and then the food usually stuck. Okay, and next is actually radiation esophagitis, which is not common unless patient got any underlying comorbid. After you exclude whether patient got any painful swallowing, the next thing is to ask whether patient got any chest pain or not. If patient got chest pain, then you are really dealing with whether the chest pain is persistent, and this symptom is persistent, which is like intermittent or spasmodic, or this is persistent. If it's intermittent, then you're dealing with diffuse esophageal spasm. Those kind of symptoms tends to be intermittent, doesn't occur all the time. But the one that occur all the time is the one like, for example, achalasia, or even pseudo-achalasia, in which there's any lymph nodes obstruction. For example, patient even have mitral stenosis and enlarged left atrium that causes compression. All those are a bit rare. Either as TB also can be possible. But generally, we need to rule out scleroderma and also Sjogren syndrome. These two is the one that we really need to rule out, especially if patient have any chest pain. Okay, and the last one is if patient have vomiting, on top of chest pain, also patient have vomiting, purging, and patient is alcoholic, for example, then you really need to think of Mary-Weiss tear, okay? Or if, let's say, Mary-Weiss tear causes esophageal perforation, which is very common in the previous format, even in one of the exam scenario in the official website in the past, is the esophageal perforation. So what we call as Bohavi syndrome. So that can also cause esophageal tear. And that can cause chest pain because they will eventually, if you don't do anything, it will develop mediastinitis. Not good. So other than reflux, odynophagia, chest pain, the next two questions you need to ask the patient is whether patient have any significant weight loss. in a patient that have achalasia, usually they will have quite a significant weight loss. But you need to compare that with the baseline. If the baseline already thin, they may not even thin out further. Their weight loss may be just almost there. Like they're just eating that little bit amount of food, and then the appetite has been conditioned that way. Pseudoachalasia is definitely, and you need to exclude cancer. Esophageal cancer is something very important for us to exclude. And the last one, the last symptom is anemia. A patient with dysphagia, esophageal dysphagia and anemia, we need to rule out Palmer-Wilson syndrome. It came out in the last year diet for BCC as well. Palmer-Wilson syndrome. Probably not BCC, sorry. It's in the history station 2 that time. So it can be, I mean the MRCP question tends to recirculate. There's always a possibility that they could come out again and test the knowledge. Okay. So that's all for this case. If no one have any question, I'm just thinking, Karen, do you want to do another scenario? Let's say there's no replacement.
Oh, okay, can.
Can do you want to do it now, or you want to rest for a while?
I rest for a while.
Rest for a while lah. Okay, all right, sure. So next I will go to next candidate, Dr. Lee. Are you there?
Hello. Hi.
You're laughing. Yeah, it's your turn. Okay, are you ready or not?
Yeah, sure.
Okay, so we will start this scenario and we give you 5 minutes. Let's time this. Okay, so all my scenario that I prepare, I only use a very fake photo generated from AI lah. So you can laugh also. But basically, I just want to tell that I don't want to give any clue on the physical sign at all based on the face or any spot diagnosis, because that is the principle. I realize that the new format, what they're going to do this is they will not give a very straightforward question patient, unless they really desperate, they want to give, like, for example, acromegaly, going to give a lot of like very obvious diagnosis. I can feel that the scenario that they choose is maybe related more to something common, something chronic, and something we need to think about it. Because if they actually give us a very rare condition, even if you get the diagnosis wrong, they cannot actually fail us also, because the diagnosis is not common. Their expectation for setting a scenario is when a doctor in the district hospital able to recognize, able to carry out management plan and diagnosis correctly. So that was the expectation. So it shouldn't be something that very, very rare. So I hope everyone understand this concept, and then we just practice the common, the hot topics, and then we will see how it goes. Okay. So we will start the timer. So 5 minutes, your time start now. Okay, 5 minutes is up. Okay, so this is the patient, Mr. Columbia. Please start.
All right. Good evening. May I confirm that this is Mr. Colombia, 48 years old?
Yeah, I'm Columbia.
All right, Mr. Colombia, I'm totally here, one of the doctor in the medical unit. Today, I would like to ask some questions and also examine you. Would that be all right?
Yeah, sure.
All right. Mr. Colombia, can you tell me what brought you to the hospital today?
Yeah, doctor, I have been passing blood in my stool for almost 2 weeks now, and I'm very worried. I think that I may have a colon cancer, doctor.
All right. Is this the first episode you have this passing out blood in your stool?
Yeah, for bird in the stool is actually these 2 weeks was my first episode ever.
All right. Is it a painless or a painful when you pass out the bloody stool?
I don't feel any pain.
Okay, so you have no pain at all.
Mm.
And is it every time that when you open your bowel that you have this pass blood in the stool?
No, so initially I feel the stool is actually mixed with a bit of maroon color like stool. Then subsequently actually I noticed, then after that it actually resolved a while. Then I noticed some blood clots intermittently until the recent 1 week it become very bloody.
All right. So initially it is mixed with the stool, then subsequently it resolved, and after that there's a blood clot when you start passing out the motion. Is that correct?
Yes.
All right. Does the blood stain on the toilet paper after you finish your bowel habit?
Yeah, sometimes it's thin.
All right. And you can see blood clot as well.
Mm.
Is it difficult to flush your stool?
No.
All right. And you see this is the first time you have this blood in the stool, but previously you did mention that just now you have do you have any mucus before this? Pass out any mucus before this?
No.
All right. Any difficulty in passing out motion before this?
No difficulty to pass motion. In fact, for the past 1 month, I feel like having a lot of loose stool, and it comes and goes. And if I don't eat anything, if I fast myself, it tends to reduce.
Okay, so means that it's improved when you are actually fasting. Is that correct?
Yeah, yeah.
And for the past 1 month, you mentioned that loose stool. May I know how many times you pass motion per day?
Oh, terrible, doctor. I pass about 5 to 6 times per day. I have to
Five
find
to six
toilet every time I go out. I really phobia already, doctor.
All right. Does this happen when you are sleeping at night?
Yeah. It happened also. I have to wake up from my sleep to go to toilet.
All right. And usually, how many times you pass motion at night?
1 or 2 times.
Okay. So for the past 1 month, do you find that besides the fasting, that actually reduce the frequency of the number of your loose stool, anything else can actually make the thing better?
Better? No, I don't think so.
Okay. Anything that can actually make the condition worse?
I'm not very sure. It seems like it comes and be relieved by itself.
All right. And for the prior to this past 1 month, how many times you open your bowel per day?
A lot. I mean, per day is about 5 to 6 times, like I say.
Prior to this 1 month.
Prior to this is quite normal, only 1 or 2.
All right. Any history of difficulty in passing motion before this?
No,
All right. Do you have any vomiting?
no,
Any difficulty in your swallowing?
no.
All right. Do you have any ulcer or any sore at your mouth?
I used to have a bit of sore in my mouth, but I think that was because of the hot weather and then accidentally bite myself. That was about 3 months ago.
Okay. Does the sore difficult to heal?
Yeah, it took about almost 3 weeks to heal.
All right. Okay. I see. It must be very disturbing for you. Yeah.
Yeah.
Okay. Any change in your weight?
Yeah, now you mention it, I think I lost about 10 kilos for the past 3 months.
Okay. Is it intentional or unintentional?
No. I actually want to gain weight. I already very thin to begin with.
Okay. Any change in your appetite?
I I try to eat less nowadays because if I eat more, the loose stool is getting worse and the bloody stool is also getting worse. I tend to eat less because of this.
Okay, we see how we can help you with that. Any
Hmm.
fever,
No,
any night sweats?
no,
Okay. Prior to all this happen, do you have take any outside food or anything?
no,
All right. Okay. Uh, do you have any chest discomfort,
no,
fast beating heart rate?
no.
Okay.
Oh,
Any joint?
fast beating heartbeat, you mean? No, no, no.
Okay. Any joint pain?
Joint pain, yes. Sometimes over my hands and especially my wrist, I
Hmm.
realize a bit of stiffness and pain as well.
Stiffness and pain. And usually, does it happen in the morning or afternoon or
Yeah,
any specific time?
usually occur when I wake up in the morning. Then subsequently, it actually resolve by itself.
Okay. Any and usually, how long it lasts?
In terms of the stiffness, it's about 20 minutes, but pain not very disturbing. Sometimes just for a short while.
Okay. Any rashes?
Rashes, as in?
Any spots or any new rash around your face or your arm or your
No,
hand? No. All right. How about did your finger change any color when it is in cold weather?
no,
No. Okay. Any passing out any frothy urine?
no.
Any shortness of breath?
Shortness of breath. I actually feel that probably because my body is a bit dehydrated. When walk a long distance, I will feel a bit breathless. But when I rest, I don't feel that. Like now, I feel quite comfortable.
So you mean that you have this when you walk longer, you will feel breathless. How about going upstairs?
Yeah, going outside also the same.
All right. Any cough?
No,
Any coughing up blood?
no,
Any headache
no,
or body weaknesses?
not really.
All right. Do you anyone mention to you to actually you look a bit yellow?
Mm, I'm not too sure, but I do feel a bit of itchiness lah, sometimes over my bodies.
Okay. And how about do you have just now any tummy ache or anything?
Tummy ache only when I want to pass motion. Sometimes I do feel a bit of tummy ache, but it doesn't occur all the time.
Okay. Do you have any past medical history?
Uh, I actually have this thing has been going there for almost 2 years already in terms of my loose stool. So
Hmm.
2 years ago, I already started to have this, but I was seen by my GP that my GP give me some medication and become better. And then I also visited him quite a few times. He told me this can be due to anxiety. He said something like IBS or something. He said this is something that not to worry. This is something that is because of my anxiety.
All right. I'm so sorry to hear that. Do you remember what kind of medication that actually he prescribed to you?
Yeah, he gave me Lomotil. In fact, until now, I will buy from the outside pharmacy because it seems working for me.
All right. How about any camera test done before?
No, no,
No camera test done before. Any and history of any operation?
no.
All right. Just now you mentioned besides taking the Lomotil, what other medication that you're actually taking?
I also take some herbs as well lah, from the Chinese pharmacy.
And
But
how long has
yeah,
it?
I only take it intermittently. Sometimes it works, sometimes it doesn't. But sometimes I still decided to take it to reduce the this loose stool.
Okay. Any are you taking any painkillers?
No.
All right. Sorry to ask, do you smoke?
Mm, I don't smoke.
How about alcohol?
Sometimes I drink because I actually have to travel to see my other company colleagues together. Sometimes we just social drinker lah. Oh.
All right. And how do you quantify the amount of unit you drink per
Mm.
weeks?
Per weeks, I don't drink every week, so maybe 1 month, maybe 2 or 3 units.
Okay. You mentioned you actually have the traveling, and
Mm.
how frequent? When was the last traveling?
Yeah, recently just traveled back from Thailand. That time we went for some our company event.
Okay. And sorry to ask some sensitive question. Do you have any unprotected sex previously?
No, I don't do that. But I did went to their pub. I
All
did
right.
went to see their all their
Hmm.
those pub thing lah. But then I didn't do anything else.
Okay. Any family history of cancer?
No cancer, but my father actually passed away due to a liver condition. I'm not sure what's it.
Okay, I'm so sorry to hear that. Mr. Colombia, I would like to examine you. So I would like to examine, looking at the vital sign, actually patient is feverish, and I would like to look at the hand. Any clubbing,
No clubbing?
any pulmonary edema,
Yes.
leukonychia.
Leukonychia? No.
Okay. Hepatic flap.
No.
All right. Look at the chest. Look at the eye. Sorry. Any jaundice?
There is tinge of jaundice.
All right. Any pallor?
Yes.
Okay. How about any what the mouth? Is there any the dental hygiene and also any macrostomia?
I mean dental hygiene was good, and then there's a oral ulcer. You can examine the mouth. Only one.
All right. Any neck swelling, cervical lymph nodes?
No, no probable lymph nodes.
Okay. Look at the chest. Any spider nevi?
No spider nevi.
Any scratch mark?
Yes, there's multiple scratch mark especially over the forearms and also a bit on the chest.
All right. I would like to examine the abdomen. Any visible mass or swelling?
There's no mass or swelling, but there is a bit of tenderness as you feel the ninth quadrant. There's a bit of tenderness over the right iliac fossa.
Right iliac fossa. All right. No mass or hepatosplenomegaly.
No.
All right. How about the bowel sound?
Bowel sound is actually hyperactive.
Hyperactive. All right. Next, I would like to look at the small joints. Any obvious joint swelling?
No.
All right. I would like to actually proceed with checking, doing a rectal examination and also check for the any inguinal lymph nodes and also the patient, get permission to check the patient genital area as well.
Good.
So,
Examiner say you can skip.
okay. Mr. Colombia, may I know what will be your concern?
Yeah, doctor, do I have colon cancer?
All right, so Mr. Colombia, based on the history and also my examination, the likelihood of cancer is lesser. However, I suspect that you are actually having this condition called inflammatory bowel disease. Don't be afraid by the name. Basically, it's a condition in which there is your body antibody is overactive and is attacking on your own body, and in your condition is actually attacking your bowel. At the same time, it might actually involve your liver as well because you are actually a little bit of jaundice. So what we can do is that we will admit you to the hospital because you actually have
2 minutes left.
and then you are having this a lot of bloody stool. So I will need to take some blood and also do some imaging tests on you to confirm my diagnosis. Yeah.
Oh, okay. So what do I need camera test?
All right, at this moment, before we can confirm that it is inflammatory, of course, to confirm the diagnosis, we need a camera test, but not in the current setting because you might actually having an active disease. And when we do the camera test, when the disease is very active, it can actually cause more complication. So we actually have to admit you to the ward and give you some medication first as well.
Oh, but you mean I may need the camera test later, right?
Yes, because to confirm the diagnosis as mentioned, we will actually have to do a camera test and also take some sample from your bowel.
Oh no, doctor, can I refuse this procedure? Because it seems very traumatized. My father previously got liver disease, got bleeding, and they did the camera test, and it was very devastating. I look at how my father suffered. Can I decline this, even if it's to be done later?
Of course, I'm very sorry to hear that, Mr. Colombia. Camera test so far is the only gold standard that we can have to obtain the tissue biopsy, the tissue diagnosis. However, if after explanation, if let's say you still refuse for this camera test, we can proceed with other small specific blood tests that can actually help in consolidate the diagnosis. However, as mentioned, it might not actually can confirm that you can have this diagnosis. And rest assured that we will ask the most professional and also the related team to actually perform the camera test.
Do I need surgery?
Okay, if the disease is very active until you have a very bad complication called in which your bowel perforated, means there is a hole in your bowel or your then we might actually have to put you for emergency surgery. However, at this condition at your level now, we can monitor first, and we have to do, as mentioned just now, imaging before we can decide. Yeah.
Okay. All right. Thank you. Time's up. Okay, Dr. Lee, can you tell me walk me through the diagnosis and your differential diagnosis?
My diagnosis for this gentleman is likely an ulcerative colitis. An inflammatory bowel disease, more specific ulcerative colitis. A Crohn's disease with likely primary sclerosing cholangitis. Yeah.
So association, which one is it? UC or CD?
CD.
With with the primary sclerosing cholangitis?
Yes.
Okay. What is your differential diagnosis?
My differential, of course, will be ulcerative colitis, also with PSC lah. Then my other differential for this gentleman will be probably colon malignancy and irritable bowel syndrome, which is less likely. And other possibility for this gentleman could be infective colitis.
If let's say it's infective colitis, what would be your possible explanation?
Because patient actually is a traveler, he frequently travel, so he might actually have contact with those protozoa or even or the microbiome that can actually cause infective colitis.
So you mean he may have a traveler's diarrhea?
Yes.
Okay, sure. So how will you work out for this patient?
For this gentleman, the basic test will be a FBC full blood count to look for leukocytosis, and probably patient might be anemic because of the chronic diarrhea, bloody stool as well. Then have thrombocytosis. Then a baseline renal function test just to make sure there is no acute renal involvement or even electrolyte imbalances due to persistent diarrhea. Then I have send an ESR, CRP level, liver function test just to make sure what's the albumin level, a coagulation profile, and total bilirubin level to see any jaundice and ALP level, any evidence of obstruction. So for the stool workout, I will have to send for stool FEME, stool OYCs, and also stool for CNS. If patient have actually money, can actually send for a stool procalcitonin. And also for imaging wise, I will have to do a chest x-ray and also a abdominal x-ray first. And from the count, everything, then only I can decide whether patient has does not have any complication of IBD before I can proceed for any imaging like colonoscopy and endoscopy for this patient.
Is there any other blood test that you want to screen for this patient? You mentioned that patient may have some liver disease, right?
Yes. So I can also send for a biohazard, which is hepatitis A, hepatitis B, C, and HIV, because patient have has been traveling and has been from other places as well. Then I can also send a gamma GT for this patient as well.
I see. Okay. So how will you manage this patient?
Oh, sorry, for blood test also, I can send for the anti-AMA and anti-mitochondrial antibody, anti-asthma, and also anti-LKM and immunoglobulin level as well. So how would I manage this patient is that this patient will need an admission because of the fever, and also patient has been having bloody stool for the past 2 weeks. She has been worsening. So probably he will have some dehydration. I will admit him to the ward. After investigation, I will start him on some IV fluid as well for replacement. Then probably start him on some loperamide to reduce the amount of the diarrhea, the loose stool. And if it all is proven to be an IBD based on the initial blood investigation, I will actually have to start him on a steroid first before I can decide whether this patient will need a mesalazine or sulfasalazine.
Yeah, you have mentioned about how about, let's say the patient has DDO involvement. There's one test that you may want to offer for this patient.
What involvement? Pardon?
If let's say you are suspecting patient have PSC, right? You have mentioned that.
Yes.
How do you confirm the diagnosis?
Oh, actually, I have to do a MRCP or actually MRCP.
Okay. So how is there any management in terms of with regards for that condition?
For PSC, actually, we can give patient also the oxycolic acid, also flux, or if it's actually not working, we can try cholestyramine as well.
Okay. So for IBD per se, other than disease modifying therapy, is there any medication that or any other thing that you want to inform the patient and counsel?
All right, so for IBD, the first line of management usually will be oral medication, which include azathioprine and if in flare will be steroid or even some maintenance dose of low dose prednisolone. However,
Other than
if
medication?
everything fails, it will be biologic MAT, which include anti-TNF alpha that has been approved. For example, the three will be adalimumab, etanercept, and also infliximab. So I have to count. Yeah.
Time stop. Okay. Wait. The question for this is actually what are the other non-medical things that you can offer and
Which
counsel
is
the
the addition or
Yeah, the addition very important. Must mention the addition.
Yeah.
Must mention the addition. And vaccination also important in this case because patient need immunosuppression, right? So it's important. So a few things I want to ask you. So the patient have CD instead of UC. What is the reason?
because it has oral ulcer, so I'm thinking it probably have a whole GI tract involved. But deep in my mind, of course, the more common one will be a UC with a PSC lah.
Yeah. So actually that is usually the common perception. Actually in UC it's also possible to have oral ulcer. That's why it's called IBD. Yeah, not necessarily. Yes, tends to occur more and more diffused from mouth to the anus in Crohn's disease, but it can also occur as well. It's not to say not possible. And then you mentioned about the autoantibody. The anti-mitochondrial antibody that you mentioned is actually more for PBC. How about PSC?
PSC will be AMA, is it? No, AMA, yeah. Is it AMA? Yeah.
Your ASCA is your Crohn's. Your ulcerative colitis is actually your P-ANCA. PSC. It's a P-ANCA. But it's not very important. That's why I didn't want to probe further. But since you already opened up, then have to make sure it's correct. Yeah. So other than that, I think you do quite well. I mean, you got most of the diagnosis lah. You got most of the point. Okay. I think not much an issue. Basically, you are also quite ready for exam. It's just that what is the thing that I want to say already?
I think I spent too much time on the history.
Yeah. I mean, for the HOPI, I understand that this is like a mixture of history station and BCC, but your history need to be a bit more concise. I tend to feel like you ask too many almost similar questions, and especially the bloody stool. You spend about 2 minutes in the bloody stool, so it's a bit too much. Right? I feel you should ask a bit more relevant kind of question. I mean, bloody stool is bloody stool, whether or not. I mean, you are not sure whether it's a local or systemic causes. You excluded the local one, like it doesn't occur like after you pass out the motion and then, but it's mixed with blood. So you know that this is most likely something deeper, right? So it's not just superficial. So after you establish that, another thing I realized you didn't ask is actually, since you're thinking about proctitis, right? You have to ask about tenesmus. The symptom. These are the symptoms that I'm waiting for you to ask. And I realized you didn't ask the full GI red flag symptom. You asked half of it, but I think of some you didn't ask. I remember you didn't ask a few things. You asked about you didn't ask about early satiety. You asked about difficulty to swallow, painful swallow, jaundice, anemia, weight loss, appetite loss, family history of cancer, yes. But for this patient particularly, you also want to add on the proctitis and the tenesmus. Another one is what was it just now? I cannot remember already. Too many things. But there's one thing that you didn't mention, which I think is okay, the early satiety, which is fine. Because you're not dealing with stomach cancer. And your anemic symptom, anemic symptom also, I remember you didn't explore fully. You explore about the exertional dyspnea, right?
Yeah.
And the dizziness, headache. Yes, you asked about headache, but I said no at that point of time. And because this headache may just occur when he actually pass out these two and then suddenly becomes symptomatic for it, and may be compensated, may not be significant. And the idea is actually this scenario when I prepare, I try not to make it a bit complicated lah. Initially, I say travel to Thailand. I want to say high risk behavior to make it complicated, but I decided not to because or else the focus will be lost during the discussion lah. But in the real exam, I believe we will give a lot of this red herring that may not be important, may or may not be important. The reason why I put Thailand is because for you to think of RED and therefore ask further on the high risk behavior. To your surprise, there's no high risk behavior, right? I want to
Yeah.
mention about the Thailand, the pola dance, all those things, but I feel a bit,
Actually, could be RED also.
yeah. So I think correct. So just a little bit recap on the screening examination when you want to find for IBD. You start with the most important thing for GI is always anemia and jaundice. We should screen for it. I realized you macam didn't ask for the any eye redness or anything.
Yeah,
right?
actually, I didn't ask about eye redness.
Yeah, if I remember correctly. So eye is also quite important. Start with the head to toe, right? Start with the eye, check for sclerotic, episclerotic, uveitis. Check for the skin, check for any oral ulcer. And yes, you were good. You asked about skin rash, in which I told you there's no skin rash. But let's say that is, you really need to ask patient to show you where's the rash. And particularly for IBD, you want to screen for pyoderma gangrenosum and erythema nodosum. And then yes, next is the ulcer part. Next is the muscle the musculoskeletal, which you really need to screen for any peripheral arthropathy. Yes, you did that, you check the hand. But remember, for all IBD patient, you also need to check for the back pain. Although didn't ask, I also didn't volunteer. But this is kind of sacral iliac is something that we need to check, the spondylar arthropathy. Despite patient no pain also, you just go to the back and feel at the back. Just feel the back like that, holding the pelvis. So I'm just going to feel like that and pain, just like that, to actually make it feel that the examiners know that you are actually checked for any axial spondylar arthropathy, right? And then yes, abdomen, the key is actually for this patient is abdomen. So what causes the right iliac fossa pain then?
Right iliac fossa pain. It could be a toxic megacolon or a mass.
In the context of UC,
diverticule.
usually, right iliac fossa is like reaching the terminal ileum already, right?
Or ilitis.
Something like ilitis, but by definition, ulcerative colitis will not involve ileum,
Ileum, yeah.
Or even small bowel. But in this condition, it's called Bradwash ilitis, possible, can involve Bradwash ilitis. And yes, I think the rest of it you did very well. So generally, if you score for this exam, you almost get the full marks already. Just in terms of the history, I think you need to cut short a bit, especially the HOPI part. Otherwise, it's quite okay. Examination also, you spend your time to examine. You didn't brush through and just rush for finishing, go to concern. And I remember, I look at the timer when you do the practice. I realized that when you go for the concern, the timing is quite okay. You actually go for concern at 12 minutes plus. Not exactly at 12 minutes, but about 12 minutes plus. And you can see that actually, I didn't manage to ask the last question. Do I need to take the medication lifelong? So you really need to make sure you budget your time. Your answer need to be short. Your answer again, same like other candidates today. Everyone you give a very long, good explanation. Too long. You need to cut short. Do I need surgery for this condition? Unfortunately, I think it's difficult to tell. You need to work out further. I will answer you if needed. I will need to also refer to the surgeon and we'll talk about it. Like that only I need to tell detail. Do I need admission? Yes, because generally your body is dry and I think your blood count is a bit low. We may need to transfuse you, need to observe you for a few days. We need to start your medication. Settle. So no need to be too long. And do you have a gut cancer? You say ulcerative colitis, autoimmune disease, right? Yeah, so you have to be a bit short, a bit more concise. Then it's just perfect to get all the concern. Okay. Okay. So you want to proceed with the next case first, or you want to rest?
Continue.
Continue. Okay. And engine just started, right?
Continue.
Okay. So let's continue. So this is a case 3. I will give you 5 minutes. I will show you the scenario now.
All right.
Okay, time's up. Dr. Lee, this is the patient, Mr. Benedict.
All right. Good afternoon. Good evening. May I confirm that this is Mr. Benedict, 50-year-old?
Yeah, I'm Benedict.
All right, Mr. Benedict, I'm Dr. Lee here, one of the medical doctor here. I would like to ask you some question and also examine you at the same time. Is that okay?
Yeah, sure.
All right. So, Mr. Benedict, I have been come to my concern that actually you have been having this weakness of your leg for the past 2 weeks. Do you mind tell me more about that?
Yeah, doctor, I've been having this weakness of my leg for almost 2 weeks now. It actually become worse. Initially, I noticed that only my feet are a bit a bit floppy. I feel a bit weak, but I still able to walk. But subsequently, I realized that the weakness actually start to spread around my ankle and then go up to my leg. And now I started to feel also weak over my thigh.
All right. So, is this the first time you have this?
Yeah, first time.
Okay. And does the weakness of the leg happen suddenly?
Yeah, it does not happen suddenly. Over the course of these 2 weeks, it's slowly progressive.
Okay. So, any pain at your leg?
No.
No pain. Okay. How about any, do you feel any numbness over your leg?
Yeah, especially over my feet as well as my ankle, I feel a bit numb.
Okay. Any like electric shock sensation?
Yeah, a bit of the kind of small shock kind of sensation, but it does not travel from anywhere else. It just stay over the my foot and also my ankle.
Okay. So recently, do you have any fall?
No,
Any trauma to your back
no,
or your neck?
no.
All right. So for the past 3 weeks, you mentioned that your ambulation, you still can ambulate, you still can walk. How about now?
No, now I cannot. I want to sit myself up also, it's difficult.
How many days has been unable to sit up?
Almost 5 days now.
Okay. Do you feel like you cannot control your bowel motion?
I I can still control.
Okay. How about your urination?
Yeah, I can still control. When I want to pass urine, I can control also.
Okay. Any leg swelling?
No,
Okay. So do you have any similar problem with your hand?
my hand. I feel my fingers. It probably started yesterday. Start to have a bit of this similar kind of funny sensation as well. But I can still grip my finger very well.
Okay. Any numbness?
No, I don't feel any numbness over my hands at the moment.
Okay. Any neck pain?
No,
Any difficulty in swallowing?
no,
Any shortness of breath that you're actually experiencing?
no,
Okay. How about any blurring of vision?
no,
Any double vision?
no,
Any headache?
no headache,
Any dizziness?
no dizziness.
Okay. And also any slurring of your speech?
Slurring, yes, I feel perhaps in the recent 2 to 3 days, I start to feel a bit slurred when I say something.
Okay. Is there any increase in your salivation?
No,
Okay. Any fitting episode?
no.
All right. Do you have any? I would like to ask you some other question that might not be related, but it's important for me to get the diagnosis. All right. So, do you have any chest discomfort?
No,
Okay. Any palpitation? Fast beating heart rate?
no,
Any shortness of breath or cough?
no.
Any loose motion?
Loose motion. Loose motion, no.
Difficulty to pass motion?
Difficulty to pass motion, no.
Okay. Any vomiting or any vomiting?
Vomiting, no.
Okay. Any tummy ache?
Tummy ache, sometimes I feel that for the past 1 week.
For the past 1 week. Okay. Prior to the onset of all the weakness, or do you have any tummy ache before the symptom of the weakness?
Yeah, I mean for the past 2 weeks, I have no tummy ache or any loose stool, but almost 1 week before these 2 weeks, about 3 weeks ago, I did have a bit of loose stool and tummy ache lah.
All right. And when you have the loose stool and tummy ache, do you have any pass out any diarrhea? Any sorry, bloody stool?
No,
All right. Okay. And do you have any joint pain,
no,
joint swelling,
no,
any rashes?
no.
Okay. Any change in your voice recently?
Like I said, a bit slurred, but I think my voice still okay.
There is no hoarseness, right?
No.
Okay. Anyone commented that your eye actually look droopy?
I'm not sure because it
Sure.
seems like normal for me, but if you
Mm.
compare with my photo, I do feel slightly droopy lah. If you want to compare from my photo.
Okay. Do you feel like this condition is better in a hot weather?
No, it's the same
No.
for me.
It's the same, huh? All right. So any difficulty for you to lift up your hands and also do combing?
No, I can do.
Any past medical history do you have?
Yeah, I have diabetes, doctor.
Mm-hmm. And how long do you have been having diabetes?
Almost 5 years.
And are you on any medication for your diabetes?
Yeah, I'm on this metformin 1 gram twice per day, glucoside 30 mg once daily. Yeah, so I only on this. Doctor did tell me that I may need injection like insulin, but I'm not very keen.
Okay. Do you have any idea about your HbA1c level if you heard of it?
Oh, the 3 monthly sugar control is about 9.5 lah.
All right, I see. Any problem with your vision or eye before this?
No.
Did you have your eye check up previously?
Yeah, previously I checked. I mean, I have an eye checkout 3 years ago. That time the
Mm.
doctor did told me to have some issue lah, but I don't feel any difference. I still can see clearly.
Okay. Any history of heart problem, a heart attack or stroke before this?
No.
Okay. When you pass urine, do you notice a lot of bubble in your urine?
Yeah. Sometimes I realize that.
Okay. But I just want to clarify your numbness, your weakness, and also your numbness is just the first time, correct?
Yeah, previously I have no such problem, doctor.
Okay. For your medication, do you compliant to your medication?
Yeah. So if you ask, it's not very compliant. Sometimes I tend not to take it.
I see. All right. So, okay. Any history of any operation done before?
No.
Okay. Are you taking any traditional medication?
No.
Any over-the-counter medication?
No.
Okay. So, sorry to ask, do you smoke?
I don't.
How about alcohol intake?
Occasionally I'm doing, but generally I don't think much lah. Only maybe few times per week like that.
All right. Okay. How about any traveling history anywhere? Do you travel anywhere?
No.
Okay. What do you work as?
Yeah, I'm working as an engineer.
Okay. And how does this affect your work?
Yeah, I feel very sad actually because I feel like I may actually shock out. It's like it seems like my whole world is gone.
All right. I'm so sorry to hear that. We will try to help you with that. And would like to ask some sensitive question. So sorry to ask, do you have any intimate relationship? Are you on any intimate relationship?
Yeah.
Okay. Do you have any unprotected sex?
Yeah, actually 1 month ago,
Mm.
because actually my wife stays overseas and I'm alone at home. So 1 month ago, I did visit one of the sex labor. Then I have a relationship with her, but I actually don't know about her status lah.
All right. I'm so sorry to hear that. Yeah. Okay. Any history of using any illicit drugs or party drugs?
No.
Okay. So when you have this weakness, do you feel like you are actually having unsteadiness as well?
When I walk, yes, I can't really balance myself.
Okay. Mr. Benedict, I would like to examine you. Would that be all right?
Oh, sure.
Okay. I would like to examine the gait for the patient.
Patient cannot walk.
Cannot walk. All right. Okay. Then I will proceed with a lower limb examination. Any
Okay.
muscle wasting?
There's no muscle wasting.
Fasciculation?
No.
Okay. How about the tone of the lower limb?
Yeah, it's generally hypotonia.
Hypotonia. All right. Any clonus?
No.
Okay. How about the power?
So power proximally is only about 2 out of 5.
Okay.
Distal is about 3 out of 5.
2 out of 5. Distal is 3 out of 5. All right. The reflexes?
Reflexes unable to elicit.
Gendrastic maneuver?
Also unable to elicit.
Okay. Coordination?
Unable to perform.
Unable to perform. How about the sensation?
You're checking for pinprick or
Pinprick.
perception. So pinprick that is a stocking distribution up to level of the knee.
Okay. How about the Babinski?
Downgoing.
Downgoing. Okay. I would like to check for the anal tone if a patient is actually grant me the permission.
Examiner say you can skip.
Okay. How about the upper limb examination? What is the tone for upper limb?
Upper limbs tone is normal. Power
No.
is 5 out of 5 for both proximal and distal.
Okay. Reflexes?
Reflexes is present, especially at the bicep, tricep, and supinator.
Okay. Sensation?
Sensation is intact.
Any I would like to check for the back. Any back step deformity?
No.
Okay. The neck, any tenderness?
No.
Okay. Next, I would like to have a look, compare the picture of patient IC and also the current face to look for any ptosis.
Yeah, there's a bit of ptosis bilaterally.
Bilateral ptosis. All right. How about any fatiguability? I would like to ask the patient to look up for 20 seconds.
So 20
Okay.
seconds, I will count 20 seconds.
uh,
Examiner say you can skip.
okay. So, okay. How about the pupils?
Pupil is equal, reactive.
Okay. The speech of the patient?
Speech patient as what you hear, actually quite okay. You don't feel any slurring.
Okay. So, Mr. Benedict, may I know what is your concern?
Yeah, doctor, is this stroke?
Okay, Mr. Benedict, from the examination and also history that I have gathered, it is quite unlikely that you have the stroke because usually stroke will present with one-sided body weakness and usually it will be very acute, means that it will be very sudden and usually it won't be slowly progressive. So what I'm actually suspecting for your condition is actually you have this, you might have a few conditions called Guillain-Barré syndrome, GBS, in which that is due to a history of, it could be due to a bacterial or a viral infection that you had actually 3 weeks prior
2 minutes left.
the loose stool or so now it's actually attacking your own body, causing the symptoms. So another possible condition is also could be because of your uncontrolled diabetes.
Is there any okay? Then will this weakness permanent for my life?
All right, so I will have to admit you because your condition is actually progressive. And so once we confirm, we have the confirmed diagnosis, for example, if it's a really Guillain-Barré syndrome, in which a GBS, we will actually have to give you immediate medication to stop the progression of the disease. However, the disease, your weakness might be take time to resolve, and usual time is actually around 6 months. And some of the patient might actually have residual weaknesses.
Oh no, doctor, I cannot walk. That means
I'm so sorry to tell you that, but we will help with the social worker and also we will offer assistance to you as well.
What are the chances that I can recover completely from this?
Chances of recovery will be around 50%. So we will have to monitor you, give you the medication, and then we will also need to refer you with our colleague of rehabilitation and also physiotherapists and occupational therapists to increase the chances of full recovery.
Do I need to take medication lifelong?
Okay, so when we discharge you, initially, if we might have to start you on some medication, for example, low dose of, prednisolone, which is a steroid. So slowly we'll actually taper the medication and you might actually not need any lifelong medication for the weaknesses. However, for your diabetes, we have to be very controlled diabetes, good control of your diabetes.
Okay.
Yep.
That's all, doctor.
Okay, so Mr. Benedict,
Okay,
I would
hands up. So, can you talk to me regarding your differential diagnosis and your provisional diagnosis?
Okay, my provisional diagnosis for this gentleman is likely a Guillain-Barré syndrome (GBS). It's actually a bilateral symmetrical ascending, I would say ascending polyneuropathy for this gentleman lah. So my differential diagnosis will be a GBS as evidenced by hyporeflexia, hypotonia over bilateral lower limb, and also patient actually have some eye involvement. Other differential for this patient could be a Miller fissure and acute HIV seroconversion, as patient actually have high risk behavior. Less likely, the bottom down the list will be uncontrolled diabetes mellitus causing peripheral neuropathy for this patient.
But patient told you she never have any numbness or tingling sensation before, right?
Yes, that's why it's less likely. Yeah.
Okay. So, which one is more likely, acute HIV seroconversion or GBS?
I will still think it's GBS given the history of GI symptoms prior to the onset of the disease.
Do you ask about any flu-like symptom on top of GI symptom?
I didn't ask that.
So okay. So let's say you are suspecting this is a differential. How will you work up this patient?
Okay, I will admit the patient and then I would like to take some basic full blood count, renal function, liver function test, and coagulation profile, and an RBS because I will need to subject this patient for a lumbar puncture if I'm suspecting of a GBS, just to look for any protein dissociation. So then I will have to do imaging, which is a CT brain, to look for any evidence of space occupying lesion or any other possibility of tumor, or then I will have to do a HbA1c to look for the although it's mentioned it's 9.3, then to see the control as well, and also a UFAM 24-hour urine protein creatinine ratio. Yeah.
Do you need an MRI?
MRI will be probably MRI of the spine. Yeah.
Okay.
And
So
nerve conduction study if it's
okay, good. Nerve conduction study. And anything else that you want to exclude a differential diagnosis?
Biohazard, the Hep B, Hep C, and also HIV testing.
Okay. How will you manage the patient?
Management, if this is a GBS, this patient need to be admitted and need to be given IV immunoglobulin for 5 days, and then need to monitor closely with a PFR as well, because patient might actually progress to a respiratory distress and also CO2 retention, which might need intubation. Then rehabilitate, and also patient need to start on steroid lah. So also have to involve our physiotherapy and also occupational therapy and rehabilitation clinic as well. So yeah.
Okay. So to ask back the question, what is the point to suggest GBS instead of acute HIV seroconversion?
GBS is an ascending paralysis. Started symmetric both sides, and then is a painless, and from with the given history of 3 weeks prior that having a so-called AGE symptom, and patient also have this on examination he actually have a bilateral symmetrical ascending weakness lah. Yeah. The glove and stopping distribution could be because of the DM as well.
But how do you exclude HIV seroconversion then? What is the distinguishing feature between two of them?
I'm not so sure. Yeah, so sorry.
Okay. So because the thing is the management for both is different. So yeah. So but you have to commit one. So you commit GBS lah.
Yeah.
So how many stages of HIV that you know before develop into AIDS?
I think it's 4. 4 stages of the sorry, 3. One is acute, one is chronic, then AIDS.
So in the initial stage,
yeah,
Yeah, I think time's up already. Okay, you can just stop it. Yeah, so actually, do you think the question will come out GBS? First
Less
impression. First impression.
less likely.
Less likely, right? So
Yeah.
and the next thing is that will GBS relates to the unprotected intimate relationship?
Yeah, that is okay, understood.
Another thing is that can HIV also manifest like AGE-like symptom and also flu-like symptom before the onset of weakness?
Can.
Yeah. So I feel this scenario is actually not that easy. Like I know GBS is definitely top differential diagnosis and especially with a bit of bowel involvement. But generally, when you examine the patient, yes, you notice a bit of ptosis, right? But generally, but you when you assess the speech, not really got any slurring, but he say got a bit of slurring lah. But the slurring can also be due to the HIV related condition. But generally will not be so fast lah, huh? And for this patient, actually you need to examine for lymph node.
Oh yeah.
Very, I mean, you very crucial. You mentioned about inguinal. I think you mentioned about inguinal lymph node or something, right? If not mistaken, before you mentioned about PR or this
Yes.
not. Yeah. So yes, but this patient you really need to offer to check cervical lymph node. Inguinal you don't want to check, maybe can, but for this patient I will check lah, if possible, because it's really high risk. And usually the inguinal are the one that easily felt compared to the cervical. So you must check this. Because if you check the lymph node, I will tell you that it's lymph adenopathy, and that makes GBS less likely.
Okay, understood.
Because the second stage, actually, there's a four and five stage. The fifth one is a AIDS defining illness, like AIDS. But actually, the second stage is a PGL, right? Progressive generalized lymph adenopathy, and then followed by this acute seroconversion phase. So actually, they may have some lymph nodes. The only thing that we manage to elicit may not have any may not enter AIDS yet, so may not have any candidiasis or oral thrush or anything, but they just have this unspecific symptom, lymph adenopathy, and come in because of this weakness. So yeah, so this patient actually is the diagnosis is actually acute HIV seroconversion. You thought about that, but actually if you able to elicit that is a lymph adenopathy, then you will need to counsel him for HIV test lah, basically. Actually, you need to counsel him lah. The scenario is actually, I didn't ask the fourth question because it's not relevant. I ask you this question. But when you
Concern.
talk about primary diagnosis is the HIV seroconversion, then definitely the next thing is you need to counsel a HIV test. And the next thing he's going to ask you when the wife is in overseas is to, can you don't let my wife know about this? And this is to target on the communication in the sense of confidentiality. But this is really HIV seroconversion on the history. But the thing is, I realized there's something that you miss in the history. You explore AG symptom and high risk behavior, and you explore a bit on the tummy pain, yes, but you did not explore any heavy metal exposure, any eating of expired canned food to suggest botulism. Traveling, yes, dog bite in rabies, especially. I know it's not common, but something that we need to exclude as well, especially. So those are the things that, I mean, we talk about peripheral neuropathy, we talk about predominantly motor, then we have to exclude all that also. Like, I mean, cannot be Charcot-Marie-Tooth, like, there's no muscle wasting, symptom onset is acute, right? But the rest of it is still possible. AIDP, or this AMSAN and AMAN, and then it can also be due to your acute porphyria. That's why the tummy pain becomes important. Acute intermittent porphyria can also cause this limb weakness, but generally they are more disturbed by the tummy pain than the weakness lah. And then lead exposure, heavy metal, and also botulism lah. I think botulism is quite important. We should really try to exclude that. And other than that, I think you're okay. I mean, in terms of management, probably for this, even if you commit this GBS, not HIV seroconversion, I think you will still get full marks in the differential diagnosis. It's just that under the clinical judgment, they will minus you because they feel they maybe think that maybe you need to rationalize, and because you cannot get the lymph adenopathy part, that's why you unable to get the diagnosis to differentiate between two of them. But HIV seroconversion definitely is something that you want to tell the patient first-handed because he already volunteered you about this unsafe intimate relationship. So probably it is it is also appropriate for him to check, because you say that he's not sure of status, right? I'm sure that he also worried, he wants to know about status for himself now. So this is something that we need to talk about it lah. But I know you can see that even with 3 minutes, you start to address concern at about 12 minutes and 12 minutes and 20 seconds, something like that. That means you have 2.5 minutes to address all the concern. But having said that, you can see that the time is not enough also. So it means that we should kind of like address the concern slightly early, but it's very difficult to gauge the exact timing, because I'm not sure whether RCP will give the 2 minutes reminder or 3 minutes reminder. Now it's not confirmed yet. Previously, all the scenarios 2 minute reminder, but now that they increase the concern, that is changing of this into 3 minutes reminder thing, which we are not sure. We are really not sure. I hope that it's a 3 minute reminder, then you don't have to be stressed with the time. You just you just wait for the ring and then you straight away go to concern. But if let's say it's 2 minute reminder, then somehow I think like what you do, but probably need to go a bit earlier, so that you can get a more time to ask. But just now I think I asked most of the question. You only left with 5 seconds, so I cannot ask you this question. Okay, but generally I think okay lah. You have any question?
No.
Okay, right. So okay, if I say that like that, we will go back to Dr. Karen. Thank you, Dr. Lee.
All right.
Thank you. So, Dr. Karen, are you back?
Yeah.
You still got energy, right?
Yeah.
Yeah. For the sake of exam, must have energy. Okay. So, you are ready?
Yes.
Okay. Let's start. We'll give you 5 minutes. Okay, time's up. Dr. Karen, this is Mr. Watson. Your time start now.
Okay, hi, I'm Dr. Karen. I'm one of the doctor in the medical clinic today. May I confirm your name and your age, please?
Yeah, I'm Mr. Watson. I'm 50.
Okay, hi, Mr. Watson. I've come to know that you are complaining of passing blackish stool. Can you tell me more about this?
Yeah, doctor, for the past 2 days, I noticed that my stool is very black, and this is the first time ever I have this problem. And when I pass motion, I also realized that my tummy is very painful.
Okay, how does this happen before?
No,
Do you notice any fresh blood in your stool?
no, it's mainly everything is black.
Okay, does the tummy pain goes away after you pass the motion?
Yeah,
Okay, how many times do you pass motion per day for the past 3 days?
yeah, every day is about 4 to 5 times though, because it's causing a lot of pain, and then I have to go toilet often.
Okay, do you feel like after passing motion you still have the feeling to pass the motion again?
No,
Okay, all right. Okay, any bleeding elsewhere? For example, nose bleeding?
no,
Okay, any bleeding from the coughing out blood or any bruises of on your body?
coughing ground blood. Sorry, again, what?
Coughing
Coughing
out
of blood. Coughing of
blood.
blood. No,
Okay, any bruises over your body?
no,
Okay, Mr. Watson, do you recently travel to anywhere?
no.
Okay, how's your appetite?
My appetite is not good because of all this uh tummy pain and also this back stool. I don't feel like eating.
Okay, how's your weight? Do you lose any weight?
No,
Do you have any fever for the past few days?
no,
Okay. Do you have any rash over your body? Red spots,
no,
purplish spot? No. Okay. Do you take any over-counter medication, buying a painkiller anywhere?
no.
Okay. Do you feel have you ever had a gastric pain?
Gastric pain? Sorry, what's that?
Pain over your upper tummy?
Yeah, yeah. I mean, I'm having this tummy pain is always over the upper part of my tummy.
Okay. How long has you been having this upper tummy pain?
It's about 1 week already.
Okay. Do you ever went to see any treatment, any camera test done before?
No.
Okay. Do you ever buy any medication to relieve the pain?
I have tried with some this milk kind of solution from the pharmacy. It helps a bit, but generally after some time it doesn't help much.
All right. Do you have sour sensation over the mouth always?
No, not
Very,
really.
do you have feeling get full very easily after like small meals?
Recently yes, but previously no.
Okay. Recently, yes means how long has it been?
Because of this tummy pain, about 1 week.
Okay. All right. Do you take any traditional medication?
No.
Okay. Do you take any blood thinners?
Yeah, doctor, I'm actually on warfarin. I'm taking warfarin 4 mg Monday to Friday, and then 4.5 mg from Saturday to Sunday lah.
Okay. May I know why do you take this warfarin?
Yeah, I was told to have a rheumatic heart disease when I was young, and then subsequently my valve went into failure, and then I did a valve replacement in 2019 lah. Since then I'm on warfarin.
Okay. Do you know that is a single valve or is a double valve?
Oh, doctor said only one of my valve is involved, and that is also causing irregular heartbeats. So need the warfarin.
Okay, so do you miss any do you go to clinic frequently? I mean on time? Do you miss any clinic?
No, I always go nowadays. I only go like every 3 monthly like that.
Okay. Do you know how's your INR range so far for the past few months for a follow up? Was it stable?
The last time I went was about 1 month ago. That time my INA was told to be 3.
Okay, so any recent change in the warfarin dose?
No. Doctor say continue because my target actually is still okay.
Okay. Any change in your diet recently? Do you notice like taking more? Do you change in your diet recently?
No, not that I know of.
Okay. Do you notice you having this yellowish discoloration of your eyes or any skin?
Yellowish discoloration of my eyes.
Yes.
Sometimes I realize that, but generally maybe I don't know. Maybe because I also drink a bit of alcohol. Probably that's the reason.
Okay. How much? You mentioned alcohol. May I know how much do you drink?
Yeah. So recently, I'm actually a chronic drinker. Like I really likes alcohol. I try to cut down, but it's difficult, especially when doctor told me after the surgery I need to cut down. So I usually drinks about 12 units per week. But
Okay.
recently, last week, about 1 week ago, I actually went for social gathering, and then I was very happy that time, and I have been doing a lot lah. So it's about 30 unit that night itself.
Okay. All right. Okay. Do you smoke?
No,
Okay. All right, Mr. Watson, I would like to ask you now. You mentioned your valve are failing. May I know, do you having less swelling over your legs?
no,
Okay. Do you have any chest pain?
no.
Do you feel breathless, especially when you are walking?
No.
Do you feel
Breathless
tired
when
easily?
walking, breathless
Yeah.
when walking, yes, in the recent 3 days after I passed the PACES 2.
Okay. Do you feel dizziness upon standing up?
Yeah, yeah. Only recent 3 days.
Okay. All right. So may I know besides change besides this, any change in your urination, water work?
I can pass urine normally.
Okay. All right. Okay. So besides changing the valve, do you have any other medical problem or any other surgery done before?
Yeah, I have this irregular heartbeat, like you say. I'm taking the bisoprolol 2.5 milligram per day. Other than that, I don't have
Okay.
any medical condition.
All right. Anything any illness running in your family that causing you to have easy bleeding, anything like that?
No, I don't know.
Okay. All right. So are you married?
Uh, I'm married. I have got 3 children.
Okay, all right. Just now you mentioned taking large amount of alcohol. I will advise you to stop taking alcohol to keep within the social limits if possible because it will worsen your condition.
Hmm.
Mr. Watson, may I know what's your occupation?
Yeah, I actually work as a business, self business lah. So my timing is quite flexible, but sometimes I need to go for a lot of this agreement with my partners, business partners.
Okay, all right. So how does this affect you?
Yeah, I can. The problem is that I'm also not a very good patient lah. You see, I only take warfarin. I will be sure I will take warfarin. Sometimes I will miss the bisoprolol because of the busy in work. Sometimes I didn't bring the medication, not eating at the regular interval as well. So this thing has been happening for the past 1 week of pain, and then now it's back is to. I feel very disturbed. I feel like is it because I'm having any bleeding?
Okay, Mr. Watson, don't worry, I'm here to help you. Okay, it's okay. We will refer you to be counseled by the pharmacy again later how to be more compliant to your medication. We will help you in this. But
Mm,
can I examine you first now?
sure, sure.
Okay, I'd like to expect the patient general inspection. Is there any audible click sound?
Yep, there's audible clip.
Okay, so I would like to look at the patient general appearance, any bruises, any pupil.
No bruises, no purpura.
Okay, I would like to examine the CVS first. Is there any click sound heard? I'd like to
Yeah,
know if the first one sound or second heart sound.
there's a mechanical click at S1.
Okay, I would like to check for the pulse. Is it just irregular?
Is irregularly
Irregularly?
irregular, but less than 100 beats per minute.
Okay, I would like to check the patient eye. Is the patient pallor or any jaundice?
Patient looks pale. There's congenital pallor. There's also tinge of jaundice.
I would like to inspect the mouth, make sure there is no perioral telangiectasia.
No.
Okay, I would like to palpate the abdomen. Is there any tenderness, especially over the epigastric region?
Yeah, there's a epigastric tenderness.
Okay, all right. Oh, I would like to check the lungs. Oh, I sorry, for the CPS, I would like to check for any murmur as well. As
There's
the
no
patient mentioned, the heart is swelling, the valve is swelling.
what murmur you particularly looking for?
Is there any mitral regurgitation murmur?
No.
Okay. All right. I would like to check the lungs or bypass. Is there any bypassal crepitation suggestive of heart failure?
Lungs is clear, equal back sound.
I just check the pedal. Is there any pedal edema?
No pedal edema.
Okay. Mr. Watson, may I know, are you driving?
No. I don't drive nowadays.
Okay. I would like to ask a bit of sensitive question. Do you have any casual partner besides your wife?
No.
Okay. Are you taking any party drugs?
No.
Okay. All right. Okay, Mr. Watson, do you have any question for me?
Yeah, doctor, do I need to be admitted?
Mr. Watson, yeah, based on your blood pressure is a bit low and your heart rate is a bit fast, and you clinically you are tired and you're feeling breathless. I'm suspecting that you're having a low red blood cell. We might need to admit you and to do further workout, and might
Oh,
even
what am I
transfuse
having,
blood.
doctor?
Um, Actually, I'm thinking that you are having all these symptoms are because your valve is failing that causes the blood to break down and your red blood cell couldn't function properly, and this causes all the symptoms you're having. You are having the low blood red blood symptoms, and we are getting tired, easily breathless, and also feeling dizzy, and also passing the blood blackish too. So I need to admit you for further workout to confirm this.
Oh no. Then can this be then can I still continue to drink alcohol, right? I'm not drinking that
Uh,
much alcohol.
no, Mr. Watson. Actually, alcohol is not good for your condition because first of all, you have already have a heart problem, and now your heart is failing, your valve is failing. So alcohol will make the condition even worse. And one more thing is alcohol can actually cause the ulceration. It can injure your tummy, especially your stomach area, and this will have you to form some injuries to the stomach, and this could cause you to have a blackish stool as well. So I would strongly suggest you to stop drinking alcohol.
Doctor, my mother actually have hepatitis B, but she only passed away at the age of 71 because of liver problem. Can I having the same condition also?
Um, from what I have gathered the information so far is unlikely due to the liver problem, but because you are taking a large amount of alcohol and you look a bit yellowish, then I think I will also screen you for this screening to make sure that you do not have this liver problem as well. But so far I think it's unlikely. It's lower down in the list, but I'll keep it in my mind to work you out on this as well.
2 minutes left. Doctor, what are you going to do for me if I get admitted?
Okay, if once you're getting admitted, I will run you a few blood tests, and if it's proven that is your red cell is too low and your blood pressure is at the low side, we might need to transfuse you with the blood, as well as after this, if we will do a scan of your heart. If confirmed that your heart your valve is actually failing, we need to refer you back to the heart specialist to see what can we do for the valve, whether we want to change it again or any other alternative. And yeah,
Yeah.
and yeah.
Doctor, then how do you know that my valve is failing, but I have no symptom, I have no leg swelling or anything?
Um. Okay. Um. Because one of the valve there's a complication of the valve is that when our body red blood cell went through your go through the valve, it may actually breaks down, and yeah, this could be one sign of the valve failing.
Oh,
Then we
okay.
need to get a heart doctor opinion on this.
Okay.
Mhm. Okay. Besides this, we will also run you a few tests, and yeah, we might offer you a camera test is necessary after we review all the blood tests.
Oh, I need a camera test?
For now, I think you don't unlikely you need, but I will put that lower down in the list. We will wait for other blood tests, we will review the other blood tests first. If necessary, only we will put you through the camera test. But for now, I don't think it's indicated yet.
Oh, that means I don't have to do now, right?
Yes. So we will do the non-invasive test first,
Okay.
then
Time's
yeah.
up. Okay, Dr. Karen, can you run through a list of differential diagnosis and provisional diagnosis for this patient?
My topmost diagnosis, I would like to rule out the BAF-induced hemolysis for this patient. And also the second one is I would like to rule out a peptic ulcer disease in view of patient having chronic alcoholic. And also um, number three is I would like to rule out overwarfarinization as well because the last anemia check was more week ago. I would like to take an test now to make sure it's not overwarfarinization.
Hmm.
And
What will
yeah,
be the cause of overwafrinization then, if you think this is overwafrinization?
um, the alcohol, the large amount of alcohol might cause the overwarfarinization because patient recently 1 week ago just went to some function and took extra alcohol. I'm thinking
Okay,
it might cause overwarfarinization. Yeah,
okay.
and also in view of the age 50 years old with blackish stool, I would like to rule out GI malignancy as well, but it's lower down in the list.
Okay. How will you work up for this patient?
For this patient, I would like to do a FBC to check whether patient is anemia or thrombocytopenia causing the blackish stool, and also do a ESR CRP, and also check for PPF.
Why ESR and CRP?
ESR and CRP, no need first.
Okay, then
Let
next.
no need first. I think so. And then PPF, I would like to check for evidence of hemolysis and also other blood parameter for hemolysis, for example, the retic count and also the uh, uh, PPF to see any hemolysis. And also, I would like to do an ECG to confirm that patient is in AF. I will do a chest X-ray. I will also to look. I will do echocardiogram to check whether the valve is functioning. And also, I would like to do an LFT in view of patient has a bit of tinge of jaundice, and do a TFT as well because patient is in AF to make sure I don't miss a hypothyroidism. And yeah, I think that's all.
Then do you think the
Sorry,
patient is,
INR. Correct, to check the INR.
yep, okay, good. Then do you think the patient needs scope?
Uh, um, For now, I think we can just wait for the hemolysis workup first. If it is suggested for hemolysis, then I think we can we don't have to go for OGDS first. But this patient definitely has risk of peptic ulcer disease and also gastric cancer because of the chronic alcoholism. So, but for now, I think I will go for hemolysis workup first before I put patient through the OGDS.
Okay. So let's say that the patient has a low HB. Do you think you need transfusion?
Yes, I need to transfer the patient in view of the patient tachycardia with borderline low blood pressure and also clinically symptomatic of anemia. Yeah,
Yeah.
I think I need to transfuse the blood.
But just now when you mentioned about the workout, GSH or GSM is not part of your workout, right?
Yeah, I should sign for GSS, GSM also.
Okay, no problem. So let's say you the HB is low and you need transfusion, and then let's say the IMR came back is 9. What are you going to do?
For this patient, I need to, my NR is 9. I need to give prothrombin complex in this case because patient has blackish stool and also anemic.
Oh,
And with the INA 9, patient has high risk of bleeding, so I need to give prothrombin complex for this patient.
okay. Let's say prothrombin complex concentrate is not available in the center. Is there anything you can give?
I can give FFP, the fresh frozen plasma,
Mm-hmm.
and also if still not available, then I'll give a low dose of oral vitamin K to this patient.
Oral vitamin K,
IV vitamin K.
IV vitamin K. Okay. How much you want to give?
I think I'll give low dose 5 mg first.
Okay. Okay. So, okay. Do you know any prognostic scoring for this kind of patient that came in evidence of upper GI bleeding?
Prognostic uh is it the broadcast score or something like that? I'm not
Yeah.
sure.
So, what do you understand about the CAF score?
I think it's have to see the scope or whether it's what is the forest classification of the ulcer. I'm not sure about this.
Okay, never mind. So I think that's it. 5 minutes is up. How do you feel it?
I don't know, very rushed.
Very rush. So my first question to you is, why do you think when you at the scenario outside, patient had the bloody stool,
Mm.
the chief complaint is bloody stool, right?
Yeah. Like package 2 for 3 days.
But why your provisional diagnosis is a WAF hemolysis? Can WAF hemolysis cause bloody stool? Brackish stool, sorry, Melina.
Mm, um, no, I think no
No.
more.
Yeah.
Mm,
So you I know your idea is there, your thought process is also there, but to put a good provisional diagnosis, we really need to answer the chief complaint. Cannot be suddenly jaundice and then you thought the MBR, then straight away become WAF hemolysis early stage. That's why no heart failure yet, which is not justified because the chief complaint is still upper GI bleed. And whether it's a stable or not stable upper GI bleed, you need to scope the patient. You cannot say, I need to wait.
okay.
And what are the criteria that you can wait? So there's a few criteria that you can wait, so-called stable UGIP. So it's actually based on the prognostic score. That's why you really need to know the prognostic score. I know in Malaysia we didn't use this score that much, but in UK, based on the NICE guideline, they use it quite frequently. Okay. So basically the Glasgow GBS, Glasgow Batchford score, is a prognostic score for intervention. So let's say the GBS is not the Guillain-Barré, it's a Glasgow Batchford score. If the GBS is actually low, then you can do the scope as outpatient in 48 hours or even up to 1 week. But let's say the GBS is actually, I cannot remember the cutoff, something like more than 1 or something, is considered high, then you need to do inpatient urgent OGDS, cannot wait. Okay, so that's the first rule. And if you look at the criteria for GBS, then you will know that INA high and all those things per se is really indicative of scope. But the problem with this patient is, before you get into a conclusion of WAF hemolysis, you should really know that this is maybe most likely due to over-raffinization. And the cause of over-raffinization, like you say, is acute alcohol intoxication or excess. And that actually cause upper GI bleed, most likely is a peptic ulcer disease. So you should put that as your provisional diagnosis. Yes, WAF hemolysis can be your differential diagnosis, but WAF hemolysis cannot explain why you are having melena. You understand?
Yeah.
So you should not put WAF hemolysis as your provisional diagnosis, because if you put that, therefore, if it's acute hemolysis, definitely we don't scope lah. We observe first, we do everything first. But the problem is, because the management difference, and if you put in this case, if you put hemolysis as your provisional, then you will not get marked for the clinical judgment, because it's a very little thing, because you're not going to scope this upper GI patient, which is quite dangerous. So that's why it's quite important for you to decide. So when you decide which one is really a provisional diagnosis, I think at the middle, when I offer you some liver history, you start to become deviated and become WAF hemolysis, and especially the past medical history came with MVR, and definitely you become deviated. But we think back as a whole, the chief complaint is still upper GI bleed, preceded by so-called gastritis kind of symptom, epigastric pain for 1 week, then followed by for 1 week, right? If I'm not mistaken. Yeah, something like that. Then 3 day history of melena. So based on this history alone, you know that most likely you're dealing with peptic ulcer disease. Okay. And what is the cause of the peptic ulcer disease? Because of over-raffinization. And what is the cause? Because of that. You have to think in this way, or else it's a bit dangerous. Sometimes the scenario like this seems easy, but can actually confuse you because got multiple issue ongoing. Now I ask you the question, if you know that this is over-raffinization, what is the cause of the jaundice then?
The jaundice could be due to chronic alcoholism causing the liver problem.
Yes, can be chronic alcoholism. At the same time, it can also be due to hepatitis B, because the late mother passed away because of the who passed away also have this hepatitis B. So there's also another possibility that we don't know whether patient has hep B or not, because can be vertical transmission, right? Although there's no high risk behavior.
Yeah.
So for this kind of scenario, we need to be careful a bit, because for this, if you're going to mark in exam, your BCC, I mean your clinical consultation mark will be quite low, because you will get the marks in terms of maintaining welfare, history, examination, sign, yes, but your clinical judgment, differential diagnosis, and your communication, maybe you will not get full mark, and maybe the clinical judgment you will get 0 because it is wrong diagnosis and therefore wrong management. So it's a bit dangerous, you can see. So you really need to think through properly when you examine, I mean, when you examine the patient and when you address a concern, you must really think through what are the top diagnoses that you want to put first. I know there's number 1, number 2, and number 3. So sometimes you have to choose between which one. Okay. So this is another scenario that if your diagnosis is wrong, then your marks is really gone, because the management between these two differential diagnoses is very different. Okay.
Okay.
So if you turn at the page 195 of my notes, you will see that the warfarin table. If those that don't have, I can actually, yeah. I mean, another thing before I discuss about over-warfarinization is this patient definitely need to screen for stigmata or chronic liver disease. I'm actually waiting for you to mention all those signs, but actually you didn't mention. So the simple, easier way is spinal nevine, gynecomastia, and also loss of axillary hair. These 3 are very easy, right? And then the subsequent one is just look for hepatic flap, and also some jaundice, and also I think ascites, and those not very important. And but generally you really need to screen for that. And remember that in exam they will not give you this kind of scenario in the sense that WAF hemolysis but not in failure one. It's a bit not tally. I mean real life can happen, but in order to have a WAF failure per se, patient must have some form of heart failure symptom. Cannot be just jaundice without anything else. So this is another clue that maybe is not very convincing to say this is a hemolysis per se. Although yes, in your differential analysis, you definitely need to rule out hemolysis. Okay, and this patient, just now I think when Dr. Lee did his case on I think it's a bloody stool at lower GI bleed, he offered to do PR. But this patient you also need to do PR It's a melina have to offer to do PR. So definitely you want to confirm that this is a melina so must do. Okay, and this patient, if you got enough time, you should ask about CAGE questionnaire, because to identify that the patient is alcohol dependent or have this so-called alcohol use disorder, you need to fulfill the CAGE questionnaire. If you ask me, a CAGE questionnaire patient is fulfilled 4 out of 4. Want to stop, eye opener, all those things he fulfilled. Okay, and then yes, you managed to ask the binge drinking, quite okay. And then actually liver disease, over-warfarinization not only because of the acute excessive alcohol, it's also maybe due to alcoholic liver disease that already predisposed to cirrhosis. So these two, I mean, even if he didn't drink alcohol also, his INR will be quite high. Okay, so this is another thing that you need to be careful also. So the cause of over-warfarinization may not be just alcohol excess. Yes, maybe one of them, but bear in mind that patient is also chronic alcoholic. So that complicates the matter further, in which the INR control will be even worse. Okay. And I would expect for this kind of scenario, if you know this is a scenario of upper GI bleed, I would expect you to mention variceal bleeding. Although I know variceal bleeding can be massive and cannot last for 3 days to come to hospital. But generally, you need to mention that as part of your differential diagnosis. And the third one, I mean, part of the upper GI bleed is the peptic ulcer disease. So yes, I mean, I did not manage to ask you the last question because the time is already reached. But generally, if you got this question, how do you answer? What food do I need to avoid?
The food that contain high vitamin K.
No, vitamin K is the opposite. So those vitamin K is an antagonist, right? It will reduce buffering effect, and therefore INR will be low, correct? So
yes,
let's say the INR is high. What food you should avoid?
the low vitamin K.
The low vitamin K. I mean, we always advise patients not to avoid. I mean, avoid eating green leafy vegetable which have a lot of vitamins, especially vitamin K, right? And also avoid some supplements, avoid some green tea, and those tend to sometimes have some vitamin K also. Those are the one that tends to, in patient that is a low INR But now this patient has high INR. Which one what kind of diet? Any things that you need to make sure they didn't take? Any juice? Anything?
Is it the cranberry juice?
Yeah. So not only cranberry juice, even grapefruit, even mango, and even those all the G I remember ginkgo, garlic, and also the ginger. So all those fruits in particular you need to avoid lah, huh? And that's all. Do you have any comment on this case?
No.
No. So the lesson for this case probably is to avoid being get carried away by the other least important complaint lah. So the most important thing still package 2. With package 2, you cannot explain why the valve hemolysis, and therefore you don't want to put the valve hemolysis as a first diagnosis lah, huh? Okay. And then another part of the history is actually, if you ask further, you should also, because you're suspecting liver disease, right? You should also ask about tummy distension and jaundice. You ask, itchiness, yes, you ask. But encephalopathy is something that we tend to forget, especially uremic enceph and hepatic enceph. So we need to ask whether patient have any difficulty to sleep at night, and whether patient feel confused at time, whether patient has any feeling feeling sick and want to turn off, vomiting. So all these things we should just screen through just to rule out encephalopathy lah. But usually, yes, usually they won't send patient this ill for exam, right? So we know that it's not possible to come an exam, but this is something that we need to exclude, because the liver can also go into decompensation. Huh? So other than that, I think most of the thing you got it lah. Huh? This is just the notes that I extract from the book 195. You can see that there's a lot of things to remember, especially this chart is very important. Basically, I just summarize from all the I classify into food, drugs, and disease lah. I think it's easy to remember in this way. And then what are the things that can, the left side is the one that can cause INR to be high, left side is cause INR to be low. I feel it's very useful because usually before I go for exam, warfarin is something that can come out in exam again and again, because some patients like moderate to severe mitral stenosis, and those that with rheumatic or those with mechanical prosthetic valve definitely need warfarin lifelong, no other choice, no, not even DOAC or anything else. So those patients, they may actually choose them to come for exam. If they choose them to come for exam, definitely the scenario will be some form of bleeding or some form of INR issue. So this kind of condition, I mean, this kind of scenario can be common. That's why it's also important for us to really well aware of the scenario. Sometimes it may be because of the antibiotic that was given, like macrolides, given treat for pneumonia, outpatient, went for GP, given some azithromycin and some augmentin, things like that, and then subsequently come in the INR high. Then you need to explore whether patient took anything or not, had explore any flu-like symptom or not. And then allopurinol generally also something important. Antiplatelet, NSAID hardly. I hardly ever see that, but the commonest cause RCP likes the alcohol. I think alcohol is one of the favorite question in exam now. They expect candidate to really know about alcohol in and out. Acute alcohol assess, and this is like 1 week ago, so should be okay, still okay. Let's say this is like you're talking about acute alcohol ingestion 3 days ago or 2 days ago, then you really need to watch out for diurnal tremors. So no longer need to, I mean, the focus other than GI bleed, you need to make sure that patient is not having any tremors, and also not having any delirium or confusion, because the next thing going to happen is the seizure. Okay, so this is also part of the thing that they expect us to know, and the rest of it not very important basically. But the disease itself, you remember that thyroid function, I mean thyroid hormone can actually worsen the INR, because thyroid function can really reduce the metabolism, because it boosts the patient into a stress body response, and then all this less important enzyme is not really functioning well already. So that's why the INR that tends to be high. And same goes to cirrhosis and vitamin K deficiency, like pancreatic insufficiency. So this one also need to make sure it's not less INR, low INR. Usually a lot of product with high vitamin K content. Soya product tends to have some vitamin K as well. So avocado, all the green stuff. And then in terms of medication, Sanjun wort also can be common for exam, because we know that this is actually the enzyme, is also part of the enzyme inducer. Okay, so other than that, other thing like we always remember the mnemonic PC-BRA, right? Phenytoin, phenobarbital, carbamazepine, still got what? BRA. R is a rifampicin, and then A is actually chronic alcohol. So these are the few things that can come out lah. I mean the enzyme inducer and enzyme inhibitor. Because this kind of scenario can come in enzyme because if we don't ask about drug history or any recent drug exposure, we may miss the diagnosis. So it's important. Remember, always ask at least until family history or female history. Only then go to examine the patient. If not, like what Dr. Yo and what Dr. Lee did was ask the full history first. Only go for examination. You can see that actually either way works. Based on this, we have already practiced about 8 scenario. Actually, both way works. There's no right or wrong. And therefore, the RCP also put there, you may not need to ask the full history before examining the patient. So again, there's no right or wrong. To me, I feel like if I'm the candidate, I will be more flexible. I will not limit myself to really want to ask the history finish, only I examine. I will go by the flow depending on how complex the case. If the case seems like very complex, doesn't seem like there's an end of it, and then I probably will go to examine the patient first. And then after that, I ask a bit of social part. Okay. So and the INA management over vaccination also need to know bleed upper GI or even intracranial bleed is considered life-threatening bleeding already. So you forgot to mention you need to stop warfarin. You must mention that. I mean, examiner and RCP they likes this. Anything that causes a side effect, they want us to mention stop. Just stop the medication, stop something. And then for example, patient gout patient, diabetic, and then now came in got abnormal renal function. They like to mention you have to stop the metformin. You cannot give, for example, you cannot give NSAID. You can only give steroid, things like that lah. They like to listen, stop. So you must mention that you need to stop or withhold the warfarin. And then what else to give? Yes, BCC, FFP, correct. And let's say the scenario is dabigatran, for example, DOAC for some other indication like AF, come in bleeding, upper GI bleed again. So you also need to know what is the reversal. Okay, do you remember the reversal for dabigatran?
I cannot remember.
So actually the dabigatran, do you know the brand name of dabigatran?
Oh no.
The brand is called Pradaxa. Yeah, Yihong there. So dabigatran, the brand name is called Pradaxa, right? The reason I'm talking, I'm asking brand name not because I want to promote the drugs or anything. It's just that because the drug reversal, which is idarucizumab, the brand name is something very very near the Pradaxa name. Yihong, yes, do you know the name?
Praxbind.
Yeah, Praxbind. Because Pradaxa is PRAX, right? Pradaxa, right? So, so Pradaxa is actually dabigatran, right? So it's called Praxbind because it bind the Pradaxa. So it's actually idarucizumab lah. But you don't need to know the brand name, but I think you need to know the generic name because as the DOAC become more available in the market, they will expect us to know. And how about those apizaban, rivazaban? What is the reversal? Do you know?
I don't know also.
Don't know. So Yihong, you want to help?
Adesanate alpha.
Which is not available in most of the center, right? Yeah. So another thing is for dabigatran, if you don't have reversal, what else can you do? Let's say the bleeding is there.
Give FFP.
May not work. It will not work because you can give PCC, correct, but PCC may not work very well because you still really need because it's a direct thrombin inhibitor, right, as opposed to the factor 10A inhibitor. So yes, actually dabigatran is dialysable. Can send patient for dialysis just to wash out the medication. It's possible. So this is some of the difficult situation that, I mean, I don't think it will come on an exam, but something that in real life also, I also encounter a dabigatran patient on dabigatran AF came in massive upper GI bleed until an obese patient cannot set line, massive, terrible, had to insert the IJ, even with the INR of 6 point something. I can't remember the INR. I think more than that. Something like 9 or 8, I cannot remember already. And that patient we decided to give. Luckily, our center we have the idarucizumab, but only two vial. So the patient need to be given 2 vial for one full dose lah. So 1 vial, 10 minutes later another vial. So it's only for one patient, It's just like it's so expensive. 1 vial is like 5,000. 2 vial is like 10,000. and that patient is, because we got full stock, we got like, it's a drug sponsored medication, so that's why we can give for free, but not every center can do that. Only selected center, like for example IJN or even Serdang, have this kind of KKN quota based item, but generally it's very expensive. Okay, so I think that's all for today. Is there any other question for me before we end our session? I think everyone is tired already. Like, oh, 5 o'clock. Okay, anticipate that it will be finished at 5:30. Okay, so let's see, got question or not? No question, so I will stop the recording as usual. Where's my recording? And then I will end the meeting. Okay, hope everyone enjoy. I know it's a long day. Those that really stay back until the end means you all really want to prepare for the exam. Okay, all the best for everyone. We will see you back, see each other back in Com Skill. Next session will be around 20, I think I posted either 26 or 27. I will discuss a bit on the showcase, because I think there's a need to revise again the showcase, especially neuro as well as the 4 station, just to go through again. So perhaps maybe every diet before that I will need to repeat this using almost the same slide again. So I hope those that joined before don't mind, because it's a good reflection. The most important thing is really getting familiar with the presentation and getting the sign for the showcase. Okay, so with that, yeah, thank you everyone for joining. You all can leave already. So don't stop the recording.